Perfect.
Well, welcome everyone. For those of you who don't know me, my name is Dr. Rosalyn Juergens. I'm a medical oncologist that works here at the Juravinski Cancer Center. And I'm hoping this is going to be the first of what may be an opportunity for us to have an annual event, providing an opportunity for patients, their caregivers, loved ones to come together and learn about lung cancer, learn from each other, et cetera. This event is sponsored by a group that is near and dear to my heart. It's called Lung Cancer Canada. Lung Cancer Canada is the national advocacy organization that supports patients and their caregivers who have lung cancer in this country. And so we're, as I mentioned, a national organization and charity. We do all sorts of things like provide education. And for those of you who've come through the Juravinski, you may have received one of our Understanding Lung Cancer books. We have them both online and in paper. We gather physicians together to help try to get drugs funded faster for Canadian patients. And we actually provide your voice when it comes to new submissions for new treatments for lung cancer, both treatments that come by tablet, treatments that come by vein, radiation, even technology. So we do lots of different things, but we also are here to provide support. A night like tonight wouldn't have come together without the support of the Lung Cancer Canada team. So I want to thank, we've got Michelle Wright over here to my right, and then we've got Winky Yao in the back. They are some of my partners in crime, and they work at Lung Cancer Canada to help support all these different things. So we've got a whole litany of speakers tonight, and there is food down the hall. I don't know if we've got a nutrition break. Fantastic, I love nutrition breaks. My kids get nutrition breaks. We didn't really get nutrition breaks, right? They get multiple of them during the day. I think that's fantastic. But there is washrooms just for housekeeping things, washrooms down the hall. Look at this, I've got a, what you want to do? Go ahead. Oh, doesn't matter, I'm rolling. We've got washrooms down the hall to the left. There is a kitchen just off to the right. There's some beverages, and then there's coffee in there as well. So why don't we kick off with our, we've got land acknowledgement. So I will officially begin this event acknowledging that we are meeting on Aboriginal land that was inhabited by the Indigenous peoples for thousands of years. In particular, we are gathering upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. This land is covered by the Dish with One Spoon Wampum Belt Covenant and the Between the Lakes Purchase between the Crown and the Mississaugas of the Credit First Nation. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. So we did this backwards because she was going to thank me and I'm going to thank her. So we're going to have a thankful love of the best. I also want to thank Wellwood. So for those of you who aren't familiar with Wellwood, they're an institution that provides support, again, to our cancer patients here in the Hamilton region. They've got this lovely facility here. And again, if you've got questions of some of the resources they provide, I think they've got some more information out by the front desk. We also have a satellite outpost at the Juravinski Hospital. It's in a little known location sort of between the cancer center and the hospital, but they've also got space at the JH there. So I'm really grateful to them for providing the space for us to get together in a lovely location as well. So why don't we get started, and I will introduce our first speaker. Our first speaker in many ways doesn't need an introduction amongst colleagues, but amongst this group, Dr. Christian Finley is one of our thoracic surgeons. He's based out of our St. Joseph's location downtown. He is our lung cancer lead at the International Benchmarking Partnership and is the clinical lead for lung cancer screening in Ontario. He's an advisor on lung cancer screening for the Canadian Task Force for Preventive Healthcare, and he's going to make me stop reading all of the wonderful things that he has done to make the lives of lung cancer patients better across this country. So thank you to Dr. Finley. And let's hear a little bit about how we're going to do better in Canada and in Hamilton specifically with lung cancer screening.
All right.
Dr. Finley, I'll just give a few slides.
Okay. So, thank you very much for having me here. It's such a beautiful space. I've picked up a few hats along the journey, as is Roz, and thank you, Roz, for having me come talk. And so I can speak from a bunch of different perspectives. I have an international hat, and I have a national hat, and I have a provincial hat, and I have a local hat. So feel free to ask me anything you want. So I've been asked to talk about lung cancer screening, and actually, next slide actually summarizes well. My granddad was a thoracic surgeon, my father's a thoracic surgeon, and I'm a thoracic surgeon. And sometimes when I think about lung cancer, I think about that as a multi-generational journey. I have my grandfather's operative reports from the 1930s, when they're just figuring out how to do lung surgery, which is at the time in its infancy. And certainly to read it is very harrowing as a surgeon because they did it totally wrong. It would have been nice.
He's rolling over his grave here to say that.
No, they were doing things a little strange. And then my dad, would have these videos downstairs, and I'd go downstairs and try to record Ninja Turtles or something on a VHS tape for those of you that are old enough to remember those things. And there'd be some lung surgery on this video that was recorded in the OR. They've been trying to innovate and learn new techniques. And then jump to myself, where we do everything now through 5 to 10 millimeter incisions. And usually our biggest challenge is actually physically removing the tumor from the patient because all the cuts are so small, we can't actually pull a lung out of a tiny hole. But also in that journey, a lot of things have changed from a cancer perspective. And I think lung cancer screening is probably, in my generation, the single greatest thing that's occurred to change the survival of lung cancer. Because as everybody in this room knows, lung cancer is really common. It's responsible for a lot of mortality, sadly, and most of the time it's identified at late stage. But lung cancer screening, and I'll speak a bit about the evidence, reduces mortality by 20%. There is nothing in medicine that reduces mortality by 20%. That is just absolutely earth-shattering. And so if we can get that out across the province, across the country, across the world, I think this is going to be, in my generation, the single greatest thing that we're going to see to change the survival for lung cancer. And so I worked very hard as a provincial lead to try to get it past all the bureaucrats and get it out and rolling, because I think it's time-consuming and expensive and logistically challenging, but I think it's worth that undertaking. So in my 20 minutes, and then however many questions you want to ask me, I'll try to rip through the background, the evidence, the program, the entire experience, where we are now and the future. No problem. I'll talk really fast. So lung cancer, you don't have to worry about the statistics, affects a lot of people. 70% of people you typically present at an advanced stage. 70% of people are smokers and 30% of people aren't smokers. And we're beginning to understand the effects of genetics. We're beginning to understand the effects of environment, like what we inhale, causing that. And we don't understand, but we're terrified of vaping and all these new things that children are taking. But however, when we get at early stage, highly curable, whether by surgery or if people are too sick for surgery, radiation. And I think we're at a time of great optimism. Because we have better drugs now, we have better everything. The lung cancer one is identified in an early stage, at the very earliest. That's a really high survival. You have to excuse my slides, they did a bit of a journey to get here, so some of them are going to look a little messy, so my apologies. When we think about different groups of people, and I threw up indigenous people here, but different sorts of vulnerable people, even by economics, by where you live, by race and ethnicity, do far worse than they should. And so when we're rolling out lung cancer screening, we're taking particular care to try to look at those vulnerable populations, because it takes a whole lot more effort to go to find someone who's unhoused to get them into lung cancer screening. I mean, clearly there's so many other factors there, but these people are disadvantaged and need extra help. I was lucky enough to go to the World Health Organization last year and work with Andre Bowie, who's in charge of non-communicable diseases, and they really had an undertaking of trying to reduce mortality by about 30% in non-communicable diseases. And so we've been doing some work trying to figure out how we're going to get there in Canada, reducing mortality by 30% in lung cancer, and a lot of it becomes getting lung cancer screening, looking at inequities, and a number of different incremental benefits to try to get patients there. Why do we screen? Well, if we know something increases people's risk, and we know that intervening early can get more people cured, that is a good disease to screen. And it took us a long time to get that evidence for lung cancer. And so when we go back to my grandfather's era in the 1970s, they tried looking at chest x-rays and it just wasn't good enough. Chest x-rays weren't good enough to get us from the screening modality. And so then the LCAP study in 2006 came out, This wasn't a randomized trial, but they started using CT scans because they were becoming more widely available. And they realized that if they used CT scans, they could identify cancers at early stage, but they didn't know yet if that would change the survival because they needed a lot of people to get that to be proven. And so, so this is just showing that they thought it was going to be a benefit, but they didn't know yet. And so then you get into sort of the 2010s, and they had these gigantic trials with thousands and thousands and thousands of people. In the United States, it was in Ellis, and it was people 55 to 74 who had a 30-pack smoking history. And they really found that if they screened them with CT scans, they could reduce the mortality by 20%. Just ignore all the fancy numbers there. I will email it to you if you want to look at it later. And then the Nelson trial, which basically everybody in Europe never trusts anything the Americans say, and they had to do their own trial and prove it's the same thing. It is subtly different, but essentially, at the end of the day, they showed a 24% reduction in mortality. So by screening people who are at high risk, you can identify people who benefit, and 20% more will survive. So everybody in the world said, okay, this is a great thing, we should do lung cancer screening. And then it became, a bureaucratic rigmarole to try to get it out and launched. People argued it wasn't cost effective, and we all know that lung cancer is socially stigmatized, and so we needed even more evidence to prove to people that it was a benefit. And so here it was that it was actually cost effective, and I'm sure all of us say, hey, $52,000 is a lot of money. But that by the economics of it, that makes it very cost effective. So where are we in Canada? BC is province-wide. Ontario is currently in 5 sites, and I'll speak to that in a second, and I'm going to roll out across our province in the next 2 years. And basically, with the work of Lung Cancer Canada, the Canadian Cancer Society, CPAC, I would bet within the next 4 to 5 years, the entire country should have lung cancer screening widely available to everybody. So how do you implement it? So people realized that just going age and smoking wasn't good enough, that you can actually do a better job than that, that if you actually do a 2-step process where you take even more people who smoked for 20 years at all, and ask them some more questions like, hey, does anybody in your family have lung cancer? Do you have a diagnosis of COPD? Other risk factors like that? Then you can actually refine who you bring in and find more cancers with less scans. So what we do in Ontario now is a 2-step process where you bring in anybody who smoked for 20 years at all, daily cigarettes for 20 years. Then you ask them a whole bunch more questions, and about 80% of those will flow through and get lung cancer screening. And then you're able to identify almost 50% more lung cancers using that 2-step process and be more efficient. Everybody gets smoking cessation. We want to make sure that the people reading the scans are of good quality, and then you can move through the diagnosis. So, I spoke to a bit earlier about how you roll out bringing people in, because one of the greatest challenges is actually finding people and getting them enrolled. And there's a lot of innovative processes. The best care right now is somebody I'm working with who sends respiratory therapists out to family doctors' offices and pulls through their charts and finds everybody who smoked and sees if they have COPD, optimizes their COPD, and now we're referring them in. And so we had a meeting the other day, and they have 900 people to send them. So my hospital are kidding, but we have 900 more people. But I think whether it's First Nation AOPT, or different ways of finding people, this is sort of one of the challenges we're facing now, how to find people. We want our navigators to communicate with people because people are scared, obviously, they're involved in it, or know someone from there. And so making sure that they communicate well, getting back to people when they phone, it's clearly going to be a fundamental component of this. I think I spoke a bit to it already, but the NLST and the Nelson were very simple. They said 55 to 74, 30-pack smoking history and income. But we're now in Ontario probably going to increase the age up to 80, probably drop the bottom to 50. I'm not saying that officially, I'm saying that unofficially.
You're not being recorded.
But that's certainly where the US has gone. And it's important to do that to reach those sort of element of the population. I talked about this sort of complicated math that we use to try to find people who are at risk. And it's actually really distressing to go out and bring people in like that smoked for 20 years and don't meet criteria and say, we're not going to screen you. That's actually really stressful to do for those of us on the talking end. And so we're trying to not confuse people and communicate that. we talk about, what is that risk? What's the chance of having it? So people that we ask all these questions to only have a 2% chance over 6 years of developing lung cancer. So that's actually, and I think that's lower than you might ask people, but that's cost effective. That's, we find, the majority of people using that. But, it allows us to give a number and talk to people and say, hey, you have a 2.6% chance of getting lung cancer. And then helps it when something abnormal comes back, saying, only about half the people who have a significant abnormality turns out that they have cancer. Still, we find a lot of false positives. When we talk about smoking cessation, it's something that helps everybody by offering it to people. And so we try to make sure that every single person who gets referred, whether they're screened or not, gets smoking cessation. At the radiology, you think that a radiology report are all perfect, but it's sort of like you and I both trying to describe a painting to each other, that there is differences in interpretation. Come on and grab a seat. Differences in interpretation, and so we want to make sure they're speaking the same language and communicating well, because they also find a lot of things by accident that they need to help people. So that was my little So we want to make sure that radiologists are reporting it in a way that is consistent. Because how they do the scan, these are all the things that you don't think about on the back end. How much radiation they do, how thick are the slices, do they get intravenous contrast, are actually really important. And actually, one of the things that's actually, when you deliver something from standpoint, is you never want to lose somebody. And so making sure that you can track people down, get the right reports, find the right people, communicate to them, and nothing gets missed ever. Because that is one of the challenges on the delivery side of things that is terrifying. The people who read, you don't want someone who reads one of these a month. You want someone who does a lot of it, and that's actually in some radiology practices in the province a challenge. They're reading the MRI one day, and then the X-ray of a toe the next day, and then the ultrasound or something the next day. They may not read a lot of these CT tests, and so we want to make sure they do a standardized volume, that we check their results, give them good training. If they're not doing well, then we bring them back up to snuff. We find things by accident, whether it's you have a bit of calcium on your coronary arteries, which is a signal of heart disease, emphysema, something in your pancreas, something in your liver, something on your eyeball. You just got to follow all those things up, find them, report them consistently, make sure we intervene upon them appropriately. You don't want to scare people to death, and you don't want to miss them. When we first did this in the province, we did a pilot and put it in 4 different sites. Depending upon where you were, it was 28 to 67% of the time we found something by accident. And it turns out when we got them in the same room and had them talk, we've now dropped that down to about 15%. So clearly different people when they're looking at that painting can interpret things differently, and what they think is scary and bad and need to raise alarms about is different. So it's why it's taking longer than we wanted to. I'm going to quiz you all on the numbers. Again, traditionally when people describe something they see in the lung, they can use really scary language. They can use words like suspicious. But we don't like any of that because it's super confusing. Like what's sort of ominous to one person is not to another. And so there's this thing called lung RAD, which is what we use in Ontario now, which is a very graded system. 1 is fine, 2 is slightly more worrisome, 3 is slightly more worrisome. For A, B, and X are much more concerning. For A, you get the scan in 3 months. For B and X, you meet me. And then we figure out what to do with it. So you just want to make sure it's very systematic. But even then, only 2 to 3% of people should be in that highest category, and only half of those are going to have cancer. The Ontario experience. So this is where I want to start. So this stuff, right? We're the newest. We want to be the biggest and the best, and so we're working hard to do that. But it's going to roll across the whole province. We did a pilot study I talked about, which is published this year, and showed that Ontario is a world leader in how we're delivering this. And so it's something that I get questions about across the country. When I was on that little tour last year, I sat down with the Scottish government who are trying to do the same sort of thing. So there's lots of people who are interested in our experience. Australia is going to undertake something similar. And it's all often about politics, but thankfully we've been able to sort of surmount that, and we have a plan to roll out across Ontario and hopefully the rest of the country, and it's, we've got something to be proud of. We were able to identify a whole bunch of people at early stage disease, which is what you want to see. So we're able to identify people at early stage disease and intervene upon them. Another slide shows this. And so what does the future hold? So I'm sure I went over my 20 minutes, but I will give you my predictions on the future. AI is going to be hugely important. I think that in particular for radiologists, the fact that we have human beings going, this is a 4, maybe 5 millimeter thing and it looks kind of fuzzy and pokey, or you can have a computer that can give you a consistent report and it's looked at 10 million reports, I think is certainly easily attainable in the next short interval. The duration between scans, if you've had 5 totally normal scans, you probably don't need to be scanned every year, so you can probably stretch those out to save people the radiation dose and the stress of it. You're changing risk if you start smoking again, as all of you know, you start smoking, quit smoking, you start smoking, and then you get diagnosed with COPD, and then something else happens. Like your risk changes. So by picking at one point, we could probably do a better job of that. And certainly we think genetics has a huge part. And we know that if you have a first-degree relative that has lung cancer, it's just as bad as heavy smoking in terms of incremental risk of lung cancer. So there's a huge genetic component that we do not understand at all. And I think that from a delivery standpoint, the stigma that we face for lung cancer and how we have a prostate lung and we have a breast cancer, we have very little for lung cancer. I think that stigma is something that I think we're going to see change in our lifetime. So now I'm going to send you on to a far better speaker.
Any questions about the
Yeah, I do. You were talking about the rollout and early diagnosis. How could that affect certain careers, professions?
That's kind of interesting. So you're talking about if you know you're at increased
You're a
risk.
firefighter,
Oh,
you're
for
a,
different occupation.
or a miner, or people
Yeah, for
who
sure.
are exposed.
There's
Yeah.
lots of
Yes.
over there. Yeah, all those things, yes. And so there's a lot of work undergoing in terms of occupational exposures. It's harder to get a number to it because you're not. It's interesting for radiation now in the hospital. We carry little tags with us all the time that measure our personal radiation exposure risk, but we don't have that for your lungs. But you can imagine certain occupations, miners, everybody who works downtown Hamilton, are at increased risk. So yes, I think it's certainly under investigation. It's just really hard to do the science side of that thing, but I think it's
I'm actually hoping Canada will get there earlier than others. There's been a group out of BC who's done some incredible work mapping where people have lived by their postal codes and looking at the air quality when they lived in those different postal codes and then linking that to their risk of lung cancer, right? Because like I said, 30%, like almost 1 in 3 people who get lung cancer never touched a cigarette, and cigarettes may or may not be the end-all be-all as to why someone gets lung cancer. So if we can start to understand some of these other risks and exposures that have come to us, then it'll help inform, because the next question usually Dr. Finley gets asked is why are you only screening smokers? Why isn't everybody getting a CT scan? And it's because of some of those risk benefits, and so as we start to learn more and we can figure out who might be at risk because they lived their entire childhood out near the wildfires in BC, that person may need to be screened for things like that, but that's a future state.
Thank you.
it's good next.
Come on in, guys.
Come on in.
There's a couple of seats,
Right there?
I can,
Communicated perfectly, there's no questions.
Fantastic. Well, thank you, Christian, so much for your time. So our next speaker is a friend and colleague, this is Dr. Callista Phillips. She is one of our partners who actually serves the patients out at the Joseph Brant Hospital out in Burlington. So she's a medical oncologist both at the Juravinski Cancer Center and at the Joseph Brant. She's the clinical lead there. She's an assistant clinical professor with us. She's actually does lots of work. I can't even get to all the things that she does with education and the like. And she actually co-leads another diseases patient outreach in life after breast cancer. So we're actually lucky to have an experienced patient speaker, and she's going to talk about some of the new treatments we have for lung cancer.
Welcome once again. Thank you, Dr. Juergens, and to Michelle Wright and to Vinky Yao from Lung Cancer Canada for this invitation to speak today, and Dr. Juergens for the kind words of introduction. I just have to get
Oriented to the tools.
is this right like this?
Just the arrow.
Get the right this arrow, right?
Yeah.
Yeah, that's what I pressed. Maybe I'll do this one.
I think sometimes if we click away on the laptop from where the slides are, it loses its ability.
Let me unplug and replug it.
Yeah, please do.
Blessings and curses of technology.
Yes.
So I really want
And
to
of
thank
course,
you
3
all.
hours ago, this was working.
I really want to thank you all for joining me today in this journey into the fascinating world of lung cancer, especially non-small cell lung cancer systemic treatments, which is today's focus. I'm going to talk a little bit about the new treatments, mainly systemic treatments and advancements and improvements. And we just heard a great talk by Dr. Finley about the screening and the improvement to survival that it will bring. And so to paraphrase,
I apologize.
that's okay.
I apologize. If you want to just tell me next slide.
Yeah.
Yes, I will say.
Advance them from
Okay. Next slide, please.
Do you think you got it?
Yeah.
So, next slide.
You want to try and see if now it's,
Yeah, maybe try now.
sometimes when you
Give it
click
a little
on
bit
the
of-
PowerPoint, it.
Oh, there we go.
Yeah.
Take some time to load.
there.
This one,
Yeah.
So these are my disclosures. As you see, I've worked for many companies that make immuno-oncology products and targeted treatments. So hopefully that makes me equally conflicted when I'm talking today. But my biggest disclosure is that it's a great privilege to be part of the journey of lung cancer patients like you and those who are in my practice, as they have really taught me such a lot and continue to teach me. I do have a lot of slides, and I thank Dr. Juergens and my other colleague, Dr. Banfield, for some of them. I talk really fast, and so that's a relevant to the current and emerging treatments in lung cancer. These are the objectives. I'm going to mainly talk, as I said, about systemic treatments in non-small cell lung cancer with a focus on immunotherapy and biomarker-directed therapy and the changing paradigm of early-stage lung cancer, the promise of adjuvant and neoadjuvant treatment. So we've all put the slide up about the statistics, with lung cancer being the most commonly diagnosed cancer and the leading killer of all cancer. And for 30,000 people are estimated to be diagnosed with lung cancer in 2022. But from the 2021 Canadian cancer statistics, the 5-year survival rate for lung cancer has jumped to its highest ever at 22%. And that may not sound great when you look at prostate, breast, and colorectal, but it's still an advancement. And lung cancer has many faces, old and young, male and female, smokers and non-smokers. And similarly, biologically, lung cancer is made up of many subtypes. And so we have the same in oncology. Tumor is rumor, tissue is issue. And from that tissue, we actually get a lot. We get what treatments we should give the patient on an individualized basis. Now, broadly, histologically, lung cancer is divided into non-small cell lung cancer, which is about 85%, and small cell lung cancer, which is about 15%. And under non-small cell lung cancer, you have mainly the adenocarcinomas, which are gland-forming cancers. They look like glands, and the squamous cell carcinomas that look like the skin cells. And you have a smaller subset called large cell carcinomas. I am really not talking today about other rarer types like mesothelioma or soft tissue sarcomas or carcinoid tumors. But beyond that, we actually have come to know much more about lung cancer, actually what is driving lung cancer. So you have these different buckets of treatment. You have cancers that are likely to be more sensitive to an immune attack. On the left, we have cancers with targetable mutations, driver mutations, and this group is growing. This is mainly in the adenocarcinoma group. Unfortunately, squamous cell carcinomas don't have many of these targets. And then you have that last bucket, no obvious target, but that is becoming smaller. And that brings me to the first take-home point, which was from an educational ad from AstraZeneca that said, a lung cancer diagnosis will test your strength and resilience and the way you see your future. Test it right back by testing it for biomarkers. And a biomarker, as has been defined by the National Cancer Institute, is a molecule found in blood or body fluids, a sign of normal or abnormal process, and it helps us sometimes direct treatment and look for the response to treatment. It's also called a molecular marker or a signature molecule. And these biomarkers have helped us actually give personalized treatment for lung cancer. We have understood a little more about what drives lung cancer, what are the genetic mutations or changes in lung cancer, and this is through better molecular biological techniques. We now have NGS, as it's called, next generation sequencing, where you can take and sequence millions of pieces of DNA and get so many mutations from a little piece of tissue. And we hopefully in the future we'll have more of the liquid biopsies where you don't really have to have these invasive biopsies, but whatever tumor shed in the blood, we can look at that fragment and look for mutations. And that hopefully when it comes, as it becomes more applicable, we will see that we may be able to use it for screening, for predicting response, and monitoring disease progression. So I put on the right a thing that shows the different stages of lung cancer through the AJCC staging 8. And it goes from 1 to 4, 4 being advanced cancers. And as we said, greater than 50% are found at this stage. I'm going to start there and move backwards into the curable state where there's much more hope. But this says, we found a mass. The good news is we have weapons of mass destruction. And those are like our chemotherapy and radiation. We still have them and they are getting better, but we now have more targeted treatments. And I know immunotherapy is not really new, but it has brought so much advance in lung cancer, and it's coming up to the early stage of lung cancer that I thought a little primer on immunotherapy was important. And so what is immunotherapy? I have used this cartoon of a virus infecting cells, and the gray cells are normal cells, the blue cells are the virus-infected cells. When the virus or the tumor takes over the cell, it takes over the machinery of the cell, and it makes all these newer antigens. They come to the surface, the macrophages pick them up, put them into the environment, and these orange cells, which are the dendritic cells, they take these antigens up and look for cells in the lymph nodes or T cells, our immune cells, that can recognize these new antigens and get activated so that they can come back and kill them by cytokines. But if this process was just going to go on and on in our body, we'd all be a big ball of pus. And so they have to be these checkpoints. Our body has to develop these areas where they say stop. The T cell can't keep fighting this. And so these checkpoints are like down here where we have the CTLA4, the T cell. When it combines with B7 on the dendritic cell, it stops the T cell from fighting any of the foreign cancers. And similarly, when we have PD1 on the T cell, has a handshake with PDL1 on normal cells, and tumor cells use this to escape the immune system. They use this PDL1 and they stick to PD1, so the T cells cannot recognize them and doesn't fight them. So what do these checkpoint inhibitors do? What is immuno-oncology one of the immuno-oncology drugs? It breaks this handshake. It takes away the checkpoint. And so it blocks, we have CTLA4 antibodies, they block the CTLA4, so now the T cell gets activated and can recognize the cancer cell. So we have ipilimumab, tremelimumab, we have PD1 antibodies, PDL1 antibodies, and these are all the names. And so this, as I said, was not new. in 2018, Dr. Honjo and Dr. Allison got the Nobel Prize for Medicine for the discovery of PD-L1 and CTLA4 and its use in cancer. And since then, we've gone on to have so many immuno-oncology products. And I cannot talk about immuno-oncology without talking about this slide, which shows the different mutations, how mutated is a cancer. And those cancers on the right they have a lot of changes and mutations. They are more likely to respond to immuno-oncology products. And so there we have lung cancer right there. So it's ripe for the picking. And so we have these immunotherapy. But can we further pick which cancers are more likely to respond? I talked about biomarkers. And so do we have a biomarker that would be able to tell us that, oh, this cancer will respond more to immunotherapy? And so the most useful biomarker we have at this point is PD-L1. And down there is a cell, when it's stained, that's a PD-L1 positive cell. All those brown staining cells. They count the number of those cells either on the tumor and give a score, or on the tumor and lymphocytes. So you can have high PD-L1, which is greater than 50%, low PD-L1 or negative, less than 1%, and those that are in between. And how is that important is that this was the trial that showed that if you took patients who have never been treated, stage 4 lung cancer, and we gave them this pembrolizumab, an anti-PD-1 antibody, and we compared it to chemotherapy, blue line being the pembrolizumab, the red line being the chemotherapy, there was definitely an improvement in survival. You can see those curves have separated right from the beginning, with the blue line doing much better. And at the end of the curve, the patients are still alive. It's called the tail of the curve. There are some long-standing responses with immunotherapy. And so the 5-year survival is approximately 25% as compared to 5% historically. So quite an improvement. And so this is the paradigm now. Most non-small cell lung cancer patients, except those with driver mutations, which I will talk about next, are going to see immunotherapy. Either if they have very high PD-L1, it will be just immunotherapy alone, or it will be a combination of immunotherapy and chemotherapy, or 2 immunotherapy drugs and chemotherapy. And these are the number of immunotherapy drugs that are now available across the spectrum of non-small cell lung cancer. But it comes with some side effects, and so this says, you said no side effects, just look at me now. And so I said minor side effects and you look okay to me. So what are these side effects? And I think this is very important to recognize, because when the T cells get primed, they can actually go overboard. The brake has been released, and so they can attack normal cells. So I tell my patient, it can be inflammation from head to toe, and itis from head to toe. So you can get something like the eye, uveitis, or the lungs, pneumonitis, or colon, colitis. Even the heart sometimes is not spared, and you can get myocarditis. Mostly when we get the single agents, we don't have much problem. Most patients will get away with minor side effects, usually thyroid gland problems, etc. But when we get dual agents, there could be more side effects. And the question is that recognizing them early is very important, because if you recognize them early, the brake can be put back on the system quickly. Give steroids, stop the T cells, and stop this, and people get better. And so we have this thing. I always say the pillars of management are education of patients and providers about immunotherapy drugs, continuous monitoring, because these side effects can occur early through the disease, and even when the immunotherapy drug is stopped, some people can get these side effects. So always to know about that, identify them early and intervene early. So we give this card out to all our immunotherapy patients, just like when chemotherapy patients got the febrile neutropenia card, the card about fever, we give it, so it tells that it identifies patients as getting an immunotherapy drug, and it tells a provider what to do or who to call if there is a problem. And so we go on to the next part, and this is when cells grow, there are actually 2 types of genes that manage cell growth, and one are the tumor suppressor genes. They stop cell growth a little bit. They are like the brake on the car, and so they stop growth. And then we have the proto-oncogenes that help cells to grow and divide a little bit. And normally there is this balance in healthy tissues. The accelerator is mostly off, the brake is working. But when a gene changes and becomes mutated, then we either have the break defected, and so there's nothing to stop the cell from dividing, and the accelerator is jammed down, and so the cell just keeps dividing without any control. And this is how, these are the driver mutations, and I'm going to use these are like these oncogenes that are just sort of moving on and causing cell growth. And I'm going to use the example of EGFR, epidermal growth factor receptor, on the surface of the cells, commonly found in lung cancer. When it is mutated, when there's a gene change, instead of, it's like a switch turns on, and this whole process going down into the cell, going to the nucleus, making the cell grow, keeps going round and more cells grow, and it's uncontrollable. But then, when we have a targeted drug that is a oral pill called osimertinib that targets this particular mutation, it goes and attaches itself to that mutated area, and it's like putting a cog on the wheel. It stops the cell from continuing to divide and kills the cells. And this has made a great difference in the lives of patients who have this particular mutation, the common mutations. As you can see from this trial, the median overall survival for these patients taking a pill is approximately 4.5 years with good quality of life, and compared to a few months to maybe a year or two with chemotherapy alone. So finding these type of mutations is so important in treatment. And so we have all these mutations now. We call them actionable changes that have targets for them, like we have targeted drugs for them, as the ALK rearrangement. We have lectinib, brigatinib. We have a ROS rearrangement. We have RET. These are all the identified mutations, and many more to come, hopefully. And this has truly, these are the agents we can access in Canada, and this has truly changed how we look at advanced lung cancer. It has improved the lives, it has given survival benefit. So if there is a driver mutation, like if that EGFR, as I said, or one of these, then regardless if they have high PD-L1 or not, they should get that pill first. That is the most important. If they don't have any of that, then they go with immunotherapy. So going now, as I said, backwards, or should I say forwards a little bit, from stage 4 to stage 3 cancers, when we have, these are cancers that they're not operable. Sometimes we have a lot of nodes in the middle of the two lungs. They are very bulky, and even a great surgeon like Dr. Finley, I think, will say no to surgery. And so we used to have just chemotherapy and radiation, and 20% survival with it, which was pretty good. But then came the use of immunotherapy in these patients. So after they got chemotherapy and radiation together, they get a year of a drug called durvalumab. And with that, 5-year survival, 43%, which is quite amazing. But coming to the real crux where we can make a difference is that we know, so people who can get to surgery will do the best. And these are a small proportion of our lung cancer patients. Hopefully with screening, this will grow larger. But these patients can go to surgery, they usually stage 1 or 2 or early stage 3. But we know that recurrences after that are quite high. And so can we do different? Can we add something to the surgery? And so we call it adjuvant chemotherapy. And this has been there since 2005. It did make a difference. There were 3 big trials and a meta-analysis that showed a 5.4% improvement in 5-year overall survival if you got cisplatin, a platinum-based chemotherapy for 4 months. And if you could take that, and of course the benefit improves with stage. How about if we add immunotherapy to that adjuvant chemotherapy? And so we have the trial down here. Sorry, I'm so sorry, I can't see, some of you can't see the slides that are down there. But you had adding a drug called atezolizumab to the immunotherapy, definitely improved disease-free survival, and also there is a trend to overall survival, especially high PD-L1. I said, no, choosing the best cancer that will respond. So this now is funded. We also have another drug, pembrolizumab, a trial that showed improved disease-free survival. So for those of higher stage, not only chemotherapy, but chemotherapy with immunotherapy earlier on. And then, what about those that have the EGFR mutation? Can we take that same thing that we used in stage 4 cancers and use it early on? Say they got resected and they have an EGFR mutation. Give them a pill for 3 years after chemotherapy. They get chemotherapy, they get surgery, they get chemotherapy, they get a pill for 3 years, and there was an 83% reduction in risk of recurrence, especially recurrences in the brain. And so this has again become standard of care early on. So we're taking all those drugs that work later on and bringing them to the forefront. Similarly, with the ALK translocation with the drug called alectinib. I'm going one step further now. Why don't we take all that chemotherapy or immunotherapy and take it before surgery, even before you can go to surgery? That's why I call neoadjuvant. And what are the benefits? The benefits are more people are likely to receive all that treatment because once people have had surgery, sometimes they are not well enough after that to get more treatment, or they don't recover fast enough and they can't complete all the treatment. So maybe they could get all their treatments upfront. Or based on what response you get at the end of that, we could either do more or less. So we could tailor treatments based on response, and that's the hope. Or they can take big tumors, make them small, get better surgery. The negative is that some patients may not get to surgery because they went through chemotherapy, because they got side effects from the chemotherapy and immunotherapy, or they progressed. And so there was this big trial that actually proved that they took patients with stage 1B to 3 from the older edition, like well-functioning patients, and they gave them immunotherapy drug called nivolumab with chemotherapy every 3 weeks for 3 cycles, or versus chemotherapy for 3 cycles. They compared it with chemotherapy because we know chemotherapy can work when we put it in that, but whether immunotherapy will do even better. Then they went to surgery, and then after that they could get either chemo or radiation. They didn't have mandated treatment. And they looked at this event-free survival, that how many people could recur, and it definitely made a difference with the arm that had both chemotherapy and immunotherapy, that green line, doing much better than those that had chemotherapy. The one on top and the one down is chemotherapy. And there was a very big difference with people who got what was called a pathological complete response. That means when the tumor was taken out finally, they could not see any cancer left. That was when you combine chemotherapy and immunotherapy, 24% of people didn't have any cancer left versus 2% with chemotherapy. So there was a big difference. We think that pathological complete response is actually a surrogate marker that these people will do well afterwards. Overall survival will be much better. And similarly, there was a trial that took an immunotherapy agent with chemotherapy, gave it upfront, and then gave them, this is called perioperative, gave some before, and then gave immunotherapy after they finished surgery. And this trial also showed a big difference with pathological complete response. So these are many more trials that have done this, and so this is practice changing. Today, there will be a lot of people who we will give this treatment to upfront. We're still deciding who are the real people who really we should do just all the treatment upfront, or give some treatment upfront, some after surgery. We don't know how to choose that. We're still deciding. All cases are discussed at our multi-case conference rounds, where we have surgeons, medical oncologists, radiation oncologists to choose the best treatment for that patient. But neoadjuvant treatment is here to stay. We hope that later biomarkers will tell us, should we do more for these patients? Should we give them more treatment after, or should we de-escalate if they did so well with treatment upfront? Surgery still remains the mainstay. We can't get away from that. So some people may say, oh, I got a complete response, the tumor's gone. You still have to go to surgery. So now we have neoadjuvant treatment. And so this is how it looks now for patients in the early stage in curative intent treatment in 2024, with all these options. And so I want to end by just talking quickly about some emerging treatments that you will hear of. And one of them is what I call the magic bullet or the biological missile. In 1906, Early said that there was this magic bullet. He described this concept where chemicals could go selectively to a microbe or tumor cell, and then in that way drop the chemo just there so that only that cell gets affected and maybe surrounding cells, so not causing all that collateral damage that chemo and other drugs cause. And so there were these monoclonal antibodies that could hone in. They carried chemotherapy with them, so an antigen that the cancer cell has, the antibody attaches, and then we have it linked to the chemotherapy molecule. And this is like the Tomahawk cruise missile. We call this the biological missile. So what it does, it goes and finds the tumor cell that has the antigen. It goes into the tumor cell. It breaks up in the tumor cell. The chemo is released in that tumor cell alone, and it kills those cells. A little bit goes out into the surrounding effect and kills the cells around. And that actually has been known to work really well in breast cancer, in some of the hematological malignancies, but now it's coming in lung cancer. You hear of these drugs, TDXD, vagal DXD, especially in HER2-driven lung cancer. So really a great improvement. And then we have drugs now that are targeting two targets. I talked about EGFR alone, now they're targeting EGFR and MET, and they can target unusual mutations. And lastly, we have these bispecific T-cell engagers. That means on one side they're targeting the cancer antigen, on the other side they get the T-cells, they bring the T-cells close to the cancer and release all these cytotoxins and kill the cancer cell. And this has changed small cell lung cancer a little bit. I said I would speak a little bit about small cell lung cancer, where we haven't had too many improvements over the years. As you can see, even in immunotherapy, we've about 2 to 3 months. And so we have this now, what I called you this T cell, the one that attaches to the T cell, one that attaches to the cancer cell, and with that, with the small cell, 40% response rate in small cell lung cancer patients that had 2 lines of treatment already. So waiting eagerly to see when this comes to practice. So my take-home messages are a diagnosis of lung cancer is no longer hopeless. We have entered a new era of lung cancer management filled with targeted treatments, tests for biomarkers. Neoadjuvant and perioperative chemo-IO shows great promise for improved cure rates. We have these emerging therapies and we look forward to it. And with this, we are redefining success in an era of personalized medicine, targeted therapy and immunotherapy, where we have the right drug for the right target, the right patient at the right time, leading to greater survival and quality of life. And with that, hopefully have this 10-year lung cancer survivors. And we have the Hope Army campaign from Lung Cancer Canada, helping to spread the word, bring awareness. And so hope is definitely growing. Thank you.
Any questions for Dr. Phillips? A lot to digest. I appreciate that. Well, our next speaker is a friend and colleague, actually. This is Karen Ellis. She is one of our expert lung cancer nurses who works at the Cancer Center. She was actually the first nurse that I worked with when I came to Canada. She taught me all the ropes. But she's actually an RN, but also an oncology certified nurse. She's actually got expertise in symptom management and actually was one of the co-coordinators for our symptom management team. And she actually helped write one of the books that I think that we've left out here on managing your breathing. And she's going to talk a little bit about managing shortness of breath.
It's one of the most common and devastating symptoms we see in our lung cancer patients. And it is difficult for us to address within the time limits of the clinic confines. I like this comment because it kind of just shows how the lung cancer patient who's short of breath feels. It's a deflated feeling short of breath. It limits your social interactions, your family responsibilities you're unable to keep, and probably some of the psychosocial people will talk a bit more about the isolating effects of lung cancer. But shortness shortness of breath is certainly the biggest driver of that. So just hoping that by the time I finish talking, you're gonna know what is shortness of breath and what we can do about managing shortness of breath. So to that end, I'm just gonna talk a little bit about normal breathing. You all do it, so you all know what happens. But it's just appreciating all of the structures that this air has to make its way through. A series of tubes, your windpipe, continues to travel through bronchi, then even smaller tubes reaching small sacs called alveoli. And there are it's hard to conceptualize, but there are millions of those, and that's what allows the oxygen then to be absorbed into your bloodstream and travel all throughout your body to your vital organs. When your vital organs are starved of it, they send out signals, and that's what makes you short of breath, because it's wanting more. It's thinking by breathing more rapidly, it's going to get more, but it's often counterintuitive to do that. So three main muscle groups that are involved in breathing: diaphragm, the rib cage muscles, and the abdominal muscles. We're going to focus a little bit about the abdominal muscles, and 8 main structures. So again, that's important because all of these things have to be open and actively allowing air through, or if they're not allowing air through, then of course you'll feel short of breath. The phrenic nerve is also important in that it gives nerve signals to the diaphragm and allows it to get bigger and smaller so that you can breathe normally. So why do lung cancer patients get short of breath? Well, there's lots of reasons, and certainly this isn't an exhaustive list because there's lots more. The first thing is underlying medical conditions, and I think we talked a bit about that. The biggest one we see, of course, is chronic obstructive pulmonary disease. However, there's also cardiac issues that can cause you to be short of breath. There's medication, it goes on and on. And things that predispose or predate you even having lung cancer. So the effects of surgery, the effects of the anti-cancer treatment, again, can make you short of breath, and complications of the cancer. So airway obstructions, as I said, all those little structures that it has to come through, and bigger ones even, and pleural effusions, which is fluid around the lung, pulmonary embolus, which is blood clots in the lungs, again, not allowing the blood to absorb the oxygen, and anemia, which is something you'll often see in chemotherapy because it affects all of your blood cells, and so depletes your hemoglobin, perhaps. Your hemoglobin is what picks up all that oxygen, that good oxygen in those sacs to take it all around your body. And anxiety, which is a chicken and an egg thing, because the more anxious you get, the more short of breath you get, the more short of breath you get, the more anxious you get. A hard thing to control. So what can we do about shortness of breath? Controlling your breathing and breathing exercises. And that's a bit of proactivity on your part, so do it before maybe you get a short of breath. Do some breathing exercises. And in the shortness of breath, getting the air you need, which is in every lung cancer packet at the JCC, but if you haven't got it, then there are a lot back there. And they have exercises on them which are excellent for all of those muscle groups that I mentioned. Lifestyle strategies to prevent breathlessness. There can be medications that help you with shortness of breath and anxiousness, and home oxygen, but just saying that that's not for everybody, and that's not the be-all and end-all. So abdominal breathing, belly breathing, allows you to get the most out of your lungs. So it helps you to do everyday things, and it's important that you practice. So the key thing is in this, I was going to have Cheryl come up and demonstrate, but we just thought in the interest of time, perhaps not. So the biggest thing is to find your diaphragm, that muscle that that moves so that you can breathe. And once you find that, so being comfortable in a chair, back supported, relax shoulders and chest, and palms upward is really important, facing upward on your legs. Then place your hand on your abdomen just above your belly button, below your ribs, and give a little cough. And that's how you locate your diaphragm. Then feeling that, once you feel that, it allows you to move that muscle up and down. And when you move that muscle up and down when you're breathing, then you're doing belly breathing rather than this breathing off the top, which is allowing your chest to maximally expand and allowing those lots of air to get to those tiny air sacs way down deep in your lungs. My other favorite thing is the handheld fan. I have sourced from your local dollar store, quite a few there, so help yourself, take them for your loved ones, take them for whoever. So they're really helpful tools, best to hold them, demonstrate. So 15 to 20 centimeters from your face, angled upward at your face, and slowly move the fan back and forth. Slow breath in, smell the roses, that's your nose, and long breath out, blow out the candles. And this allows you, hopefully, to catch your breath quicker and manage breathlessness. Lots of our patients will have them at the top of a stairway in their glove box so that they can recover from breathing, from a shortness of breath episode. And how do you slow your breathing down? Well, you have to breathe more gently, and you have to ground yourself and gain a sense of control, which is easier said than done, I understand, but it is just concentrating on that, slowing yourself down. While in bed, you might want to raise the head of your bed and lie on your affected side if you can. And if you don't know which is your affected side, then you can ask your doctor. And what we would think about a sideline person for like what would be best for breathing to allow your chest to expand to the most it can. Exercises, these are my favorite ones. And again, they're outlined in the book. And I guess I want to stress, don't wait till you're short of breath to do these exercises, because we want your chest wall, all of those muscles I described, to be nice and strong so that when you're short of breath, you can actually gain some control. So you're better armed to be proactive on this. Everyday activities, understanding what makes you short of breath, plan your activities at a pace that is right for you, and make sure you have enough time and you're not rushed. Have family members help you as you can, and it's normal to feel tired, and that's a hard thing to do too, is normalizing feeling fatigued. But we really do encourage you to do that. So the biggest thing I think people are scared of is stairs and slopes, and this really limits people. They don't go out to a restaurant because they have stairs to the bathroom or stairs to get up to it. And abdominal breathing, as I described previously, and certainly it's outlined again in the Getting the Air You Need book, really can help with breathlessness in that it just allows you to take in a maximum amount of air. So climbing the stairs, I like to explain this to patients if I have time. Standing close to the stair, take the handrail in, breathe in as you lift your leg up, and breathe out as you place your leg down and then raise your other leg. So as you can imagine, that's going to take you a long time to do the stairs, but the hope is that when you're at the top of the stairs, you're not out of breath, and you did them successfully. Pacing yourself is always really important. Allow yourself a rest between activities. Organize your kitchen so that the things you use every day are really close and you're not having to reach and really move things too much. Make your life practical. Walk more slowly, don't walk and talk, and let others do your chores. So medicines also can help you with shortness of breath, and your doctor can prescribe medications such as morphine that slows down your breathing, and then it allows you to take in more air because it's slowing your breaths. Also anti-anxiety medication that can help you with breathing similar to slowing your breath and hopefully less anxious thoughts, and so you're comfortably breathing as well. Important to remember, get in contact. So your shortness of breath can be your body signaling there's something wrong. So it's really important if you have what we call acute onset, or if it comes all of a sudden or you wake up with it, it's really important that you either seek medical attention or call into your doctor. And get in contact with your healthcare team if your breathing gets a lot worse over a short period of time. If you're feeling dizzy or unwell, or new or increased chest pain that accompanies the shortness of breath. If you have fever or cough, these all probably make sense to you, or your breathing's more noisy. If you wake up and you're suddenly short of breath, then obviously all of those things would signal you to seek medical attention. So I think that's all. I'm just gonna encourage you to take the books home, put them beside a comfortable chair that you have, and try to do some of the exercises proactively if you can. So I think that's all. Any questions? The nurses all know this stuff, so you can ask any of your clinic nurses.
Thank you so much, Karen. But I want to thank Cheryl in the back. So Karen and Cheryl are two of our expert oncology nurses who work at the Cancer Center. Literally, I think everything would come to a screeching halt if we didn't have their support. So I want to thank both of them for all the work that they've done. So before we take a break and grab a snack, it's my honor to introduce Joanne. I'm going to make sure I get this right. Baradzie. So Joanne is one of our regional lung cancer patients, and she's going to tell us a little bit about her story.
My cancer journey began in January of 2020 when I was on vacation in the Caribbean. I'd gone snorkeling for the first time ever and found myself swimming alongside a very large school of tropical fish. There had to have been at least 100 of them. They were electric blue in color and stunningly beautiful. I was entranced. Suddenly it occurred to me that I should pick my head up out of the water to see where I was. When I did, I found myself past the break wall, where the ocean current eddied and formed a whirlpool that I had swum right into the center of. I found quickly that I wasn't strong enough to swim out of it. Salt water was going into my snorkel, into my nose, and into my mouth. I was starting to panic. I started shouting for help. A big burly guy swam out to me and got me to the deck. I could hardly breathe. My lips were turning blue. An oxygen mask appeared from somewhere and was popped onto my face, and then an ambulance came and whisked me away. At the hospital, I was still having great difficulty breathing, and chest images were taken. As the doctor approached my bedside with the images in hand, I burst into tears, whereupon he asked, "Why are you crying? I haven't even told you anything yet." I was crying because I felt so bad to have done something so stupid as to not pay attention to my surroundings and to have landed in the hospital. As soon as the doctor told me they'd found a 4.5 centimeter long tumor in my left lung, I stopped crying instantly. I was there for a reason. The incidental discovery of the cancer would give me a better chance to survive longer and to survive better. When I look back, I can see the breathlessness I felt when I walked my dog up a gentle incline was a symptom of the growing tumor, but at the time I thought, oh, I'm getting old, and geez, I'm out of shape, I better get back to the gym. Not too long after coming home from my vacation, COVID hit, and the world changed pretty much overnight. My partner of 10 years told me he couldn't deal with my cancer and COVID and left. He said, "You must think I'm a terrible person." I didn't think that. I was surprised. But there's great wisdom in the words. People give what they can. We were all created with different strengths. Although I would have stayed with him had the roles been reversed, and although I was surprised that he could not help me, I got past the negative feelings. I felt gratitude for the wonderful times we had shared, and I held on to those feelings. Someone wise once said, "If you focus on the hurt, you will continue to suffer. If you focus on the lesson, you will continue to grow." A few weeks later, I started the requisite chemo and radiation sessions without a caregiver because, of course, no one could come into the hospitals in April, May, and June of 2020 due to COVID. Those were very strange times. During that time, my dog died. On one of our walks, she found a part of a peach, including the pit, which she scarfed down before I could grab it from her mouth. The pit perforated her intestine, and after surgery, she went septic and had to be euthanized. I was heartbroken and racked with guilt. I believed that I hadn't taken proper care of her. Meanwhile, I took advantage of the dietitian services the hospital offered. I wanted the best chances for maximum impact of the treatments on the cancer. She told me the number of grams of fiber and protein I should ingest daily for my weight and for my treatment. I started a logbook, and whether I felt like it or not, I ate every gram of protein and every gram of fiber every day, and religiously kept the log up to date. My diagnosis had been stage 3C adenocarcinoma lung cancer, mutation EGFR on exon 21, L861Q. This particular mutation is uncommon. In fact, the oncology nurse at that time had never heard of it. That felt isolating to me. I didn't want to feel alone on a desert island, so I started a Facebook group for people who also have that same uncommon subset of the EGFR mutation. Now there are 129 of us in the group. We don't do anything very special, but we're there for each other. We don't feel alone or isolated. That in itself is invaluable. There are many groups on Facebook that offer support. I also belong to the Tigrisso group, the EGFR group, the Canadian Lung Cancer Advocacy group, and the Cancer PEP group. When I was first diagnosed, I needed relief from a crazy mad rush of overwhelming feelings and emotions that were short-circuiting my brain. And so for a period of time, each morning when I woke up after I had my morning coffee, I would write the letters C-A-N-C-E-R on a piece of paper, and then I just burn it up in the sink. That felt so good. Just to watch it burn and smell it burn and see it turn into an insignificant little tiny pile of ash. Try it sometime. When you have a troubling thought, just write it on a piece of paper and then just burn it up. Losing hair after chemo was unnerving. Our hair is our crowning glory, and I just couldn't find a way to look on the bright side of heading toward baldness. For an extended period of time, I didn't cut my hair, and every day I put it in a top knot after I teased the heck out of it so it would look like more. Once a week, on Sunday morning, I would brush my hair and take the week's harvest from the brush, flatten it down, and compare the quantity against the previous week's harvest. Perhaps you can imagine my joy when it was apparent that the weekly loss was diminishing instead of increasing. After losing maybe 1/2 to 2/3 of my crop, little by little it has all come back. For a period of time I had foot problems that were likely caused as a side effect of the medications. It was impossible to walk daily as had been my habit. That made me feel depressed, especially since the podiatrist told me that foot problems were not likely to be corrected. He was wrong, and now I'm hiking and walking as much as I ever have. Skin rashes have come and gone. I'm sure there will be other issues to deal with in the future, but they will be dealt with as they arise. After the treatments, I learned that the main tumor had shrunk by 85%, and some of the other nasty nodule bits had disappeared entirely. That was encouraging. However, in September 2022, I learned that the cancer had metastasized, not throughout my body, but rather confined to the chest area. Considered stage 4, but oligometastatic, which if I understand correctly is kind of halfway between stages 3 and 4, but for travel purposes, insurance purposes, it's stage 4. Not too long after the metastasis, I asked for palliative care. People often mistake palliative care for end-of-life care. The last chapter, however, that's just a small part of it. Palliative care is mostly symptom management of physical and psychosocial symptoms that present with a cancer diagnosis. In fact, a new study just released shows longer life expectancy and survival rates for those who have had very early palliative care. The more perspective I have available to me, the less isolated I feel. The less alone I feel, the more productive, positive, happy, helpful, and fun I can be for all the people I care about in my life. They say the way to become a better skier is to follow a better skier down the hill. In this way, I've chosen a few influencers to assist me in my cancer journey, unbeknownst to them. They're amazing, real, and positive people. Dan Wanzer is the first that jumps to mind. Although I've never met him or spoken to him in person, it just goes to show how any person can be a positive light for others. Dan has been on his cancer journey for going on 20 years now. There have been many hills and valleys that he has traveled, yet he has an amazing, positive, honest, loving, giving, and caring attitude that shines through in his writings. An inspiration he is. His book can be purchased on Amazon, and he has an online blog as well. I try to surround myself with the Dan Wanzers of the world. Let's talk about Aunt Betty. We can't avoid her. She's at our Christmas table, or our grandchild's birthday party, and who knows if she means well or not, but she never says the right thing. Is she uneducated, ill-intentioned, clumsy with words, socially awkward, or who knows what? But she always manages to say something that leaves us feeling a rush of mixed emotions. I had an Aunt Betty who, after me telling her about my cancer diagnosis, her response was, "Thank you for telling me, is it contagious?" I have learned not to feel irked, annoyed, or angry when Aunt Betty or her clone doesn't say the right thing, the thing we want to hear, or the thing we need to hear. We are all individuals with our own unique capacities, talents, and shortcomings. If we don't get what we need from Aunt Betty, chances are it will come to us from where we never expected it, and it will come as a joyful and delightful surprise. And we can learn from Aunt Betty what not to say to others. So many resources are available to us. Like this. Thank you. Lung Cancer Canada, the Facebook support groups, the awesome people at Wellspring, Wellwood, the network of healthcare practitioners at our hospitals, and so many more. But there is one group in particular I would like to mention especially, as they have helped me so very, very much. The Cancer Patient Empowerment Program Group, also known as Cancer PEP. I became involved with them in participating in a 6-month research trial program that began January 1st, 2023. It is run by oncologist Dr. Rob Rutledge and research scientist Dr. Gabriella Ilya and their team out of Dalhousie University. They basically taught me how to live well with cancer. Cancer 101, if you will. When I was first diagnosed, the only thing I knew how to do was to assess my medical team and determine that they were believable and trustworthy, and then just put my medical care in their hands with a blind leap of faith. And I'm most grateful for their presence in my life. They are wonderful. But merely accepting care did not put me in a position of power or control. The PEP group gives me that power. It is comprehensive in scope. It addresses the whole spectrum of what it means to have cancer and what I can do about it. They are science-based: nutrition, sleep hygiene, exercise, fasting, social connectivity, meditation, gratitude, creating an anti-inflammatory environment in the body, concerns around alcohol consumption, online meetings, daily videos, customized support groups, and so much more is what they offer, and I found it to be of tremendous value. It has given me the power to do something beyond merely accepting the drugs and interventions recommended by the medical community. I found the 6-month trial so valuable, I registered for a second 6-month session. Oh, in conclusion, cancer is a big part of my life, but it isn't all of my life. It may be the death of me, but maybe not. In November, I was in a major auto collision where my car was hit by a transport truck, spun around 180 degrees, and then hit by an SUV. My car was totaled, driver's door had to be pried open to get me out, and I could have died. Yet here I stand before you. I figure the key is to live each day as well as I'm able. I've learned some things that I try to live by. I would like to share some of them with you now. Number 1, food is medicine. What I eat affects the chemistry of my brain and the health of my body. Number 2, the happiness of my life depends on the quality of my thoughts. Number 3, I give and get lots of hugs. The more the better, the longer the better. Hugs help to control blood sugar, regulate metabolism, reduce inflammation, assist with memory, regulate blood pressure, and release the feel-good hormone to our bodies. So I hug everyone as often as I can. Overall, this cancer journey has been amazing by the level of caring I've received from so many different directions. And I would like to thank all of you for listening to this evening. Thank you.
So we're going to start the second half of tonight's meeting with another patient story. I think they're going to outshine all of the doctory type stuff. So I'd like to invite Marie up. Is Marie?
Sort of here.
Right there. Okay. I felt welcome to Aging Eyeballs, Marie. I can only see things at a distance. I can't see things from close up. So I don't. Do I get to introduce?
Sure.
You? Yeah. So I've got a bio from Marie, which I didn't realize that she's actually born in West Germany. Even cooler, he played goal for the Saskatoon Blades in the WHL. He has his bachelor's in physical education from the University of Alberta, and he worked in pro hockey for over a decade as an equipment manager for the Cape Breton Oilers and then the Hamilton Bulldogs. He began working here at Mohawk when it opened in 2005, and he finally retired in 2021. So I'm going to let him tell a little bit about his story of his diagnosis.
Hi, Murray, I'm 2. I know that I'm 2 years old because 24 months ago-ish, kinda, I got diagnosed. I got told that I got a fist-sized cancer tumor in my right lung. The guy that told me about it, him and I went back a few years. A few years before that, he was the guy that pumped off a liter of fluid out of my right lung. Guess which lung gets the tumor? So Mr. Puxa, Dr. Puxa, fantastic man. He recognized me when I came in. He puts this x-ray up and he says, "See this, Murray?" I said, "Yeah, that looks like a nice chest x-ray." I'm pretty proud of that. Yeah. That's cancer. That was my first one. Welcome to cancer. Things just sort of progressed from there. I couldn't hardly breathe, I couldn't hardly walk, I didn't really know what was going on. My memory was starting to go. So we went down this road. The very first time I met Mr. Puxa, it was about 10 o'clock in the morning, he said to me, "Murray, what are you doing about 2?" I don't know what I did. So we across the street, we went, and that's when he tapped my lung. I didn't know you could tap it. And all that means is it took a great big Jesus needle attached to it. Looked like a Canadian Tire transfer pump and just sucked that stuff into a jar. All right, boom, I could breathe. Just like that. I thought, hey, this is. Years go by. Not quite 1,000 games, 500 games of hockey go by. Of quite a few years of working at Mohawk before I started to go by. And here I am. It's sort of getting to the end of COVID. I'm having a hard time breathing. You know, maybe I need a chest X-ray. And that was the second time. That was the impetus for the second time. Quite a gentleman. We went right after that brachial thing, right out of the gate. He's jamming that stuff down my throat. He's coming to a bunch of blockages and going. I wake up. I chat with him. He goes, I have to introduce you to your new oncology team. Mrs. Juergens. She was fantastic. She knew more about cancer than I did. Even though I owned it, doesn't matter. And so we started the long haul through, I got every test. You guys name it, I got it. They were taking chunks out of me, they were poking me, they were dropping nuclear bombs down me. Of course, they were calling them seeds at the time. I was going, what the hell is that? You can't fool me, that's a nuclear bomb. So they burned their way in and I could breathe. I started to get better. Shortly thereafter, or in and around that time, I was told that I need a blood transfusion. I don't know if anybody's had one of those before, but it's a relatively simple thing. You have to have a bag of blood, and you get it, and you leave, and you're happy. Of course, I didn't really understand, and I was kind of foggy, so one of the questions that I did ask was, hey, where's all the bad blood go? Is it like a one in, one out? No, it all stays in. So that was good. The other cool part about this, it was the TSN turning point of the whole thing. I had to get wheeled in by my white van. Wheeled in, pushed me up there. This fantastic little lady, her name is Olivia. She's still working in the chemo suite as a matter of fact. She hooked me up, gave me this bunch of blood. I got up out of that chair and walked home, and I've never not walked home since. Just for blood. Fantastic. And I started getting hooked up to, well, Murray, we think we're going to take a biopsy of you. And great. So we did that. We biopsy, PET scans, we got all this, and I'm really confused, like, why isn't anybody doing me any good here? I'm still feeling like crap. Turns out that I have all of this small cell lung stuff that is the perfect thing for Pembroke. I got no idea. So we find out that I'm the perfect guy. We start my 36 cycles in and around 2 years ago, minus a couple of weeks. So I've gone from being riddled from head to toe. You can't count them. How many are there? Well, we can't count them. Do you know where they are? Yeah, we know where most of them are. All right, so we got the fist size one. We got one that's as big as your finger. We got, like top to bottom, riddled, bone, everything. Not looking good. The one thing I did not do at that point was go to everybody's favorite doctor, Dr. Google. I didn't go to that guy. Didn't know him, didn't want him. I trusted the people that were standing 3.5 inches from my face, telling me, this is what we're gonna do. We're gonna hook you up to this stuff. Probably gonna be okay. So I've gone from fist size, or relatively fist size, it's just easier, 10-point, who cares, centimeters by a bunch of centimeters the other way, it's bigger than your fist. And some other small ones. And as the scans have gone by, I actually started to feel better and get better. And I asked one of the acolytes, as I call them, a really nice fellow lady, I think she was, doctor, fantastic person. Just happened to have the hijab and all the rest of that, just fantastic lady. And I asked her, can I have a printout of this stuff? Like, am I allowed to actually look at it? Yeah, you won't know what it is. I said, yeah. Just make a before and after shot, would you? Because at this point, we went from fist size to half a fist size. So you could visually see it without a little micro thing or anything like that. You could see that I was getting that. Dr. Juergens, what are you gonna do, put that in your fridge? Yeah. Put it on my fridge, and then everybody got to see. It was a really good learning tool, and it was a really good positive tool for me. I could, every time I went into that fridge and nothing was in there because I couldn't eat very much, but I could walk by the fridge. And one of the hardest things through my journey was I went from a robust, what you see now, to about 140 pounds. I was thin, I ached, couldn't breathe, laid on the couch, coughing all the time, the whole thing. So one of the things that we did was put Murray on a seafood diet. which included seafood. So the word meant to me was every time I had to go buy food, I had to eat it. And I thought to myself, yeah, I know a little bit about nutrition stuff, so I said, the hell with this. Not only am I drinking my 3 Ensures and doing all the rest of that stuff, but I'm going to Dairy Queen every day. And I'm buying that large ice cream cone and I'm just going through it. Where I grew up in a small town in Alberta, there was no such thing as Dairy Queen. Oh, what a lovely day it was when I discovered Dairy Queen. Anyway, to move on with this journey, we've had a lot of ups. We've had very few downs. We've had a few really funny things that's occurred to me, on the way through. I had to learn how to go to chemo every 3 weeks. It's been a part of my life for 2 years. I don't know what I'm gonna do next week. I'm supposed to go to chemo next week. But no, now I have to get a hold of getting on with living. That's been one of the hardest realizations, is that, the end is not nigh. Things are looking pretty good. My tumors are shrinking, even Mrs. Juergens will tell you, it's not supposed to be shrinking anymore, but it is. So, we're down to the end of your finger. Compared to what I had, I could care less. Poor Dr. Chris back there, it would take him 5 seconds to pull out what's there now. No, don't be foolish. So, a lot of this, one of the other, before I close, one of the other funny stories was, okay, it turns out that cancer people have thick blood. Every time I would go into the chemo suite, they would say, are you on blood thinners? No, I'm not. Oh. And they give you that little stink eye, really? Turns out, yeah. One of the scans showed I got a blood clot in my leg. All right, so that's no big deal. So, I go to the thrombosis clinic and they're giving me this and they're giving me that. And I'm going, how come I did? Is this going to be a life sentence? What kind of drug is this? What are you guys giving me? Well, we're really recommending warfarin. I said, I'm not taking any radical. Find something else. So they did. And, I'm chatting with Dr. Green, I think his name was, really funny. God love him, I said, can I just get off of this? I suck at taking it. What do you mean you suck at taking it? Well, I got about 12 left. I'm supposed to have 0 left today. I suck. All right, well, there's a thing on your phone you could do. I said, there's a thing on your phone, that app thing? A, you gotta remember where your phone is. B, you gotta pay attention to where your phone is. Okay, so that was good. So I come up with my other immunal strategy, so to speak, which is when you take your drugs, is when you remember. I think that's a really important, I learned that with a transplant friend of mine way back in the mid-80s. He got a kidney, and that was his rule. When you take your drugs, you take them when you remember. Is it the best strategy? No, but it seems to work. I don't have 12 left over after 6 months anymore. So, I'm chatting with him. I said, is this going to be a life sentence? He said, well, maybe. If one of those clots lets go right now, if you forget too many times, it's going to travel to your lung and kill you. I started laughing. I said, you remember, you are talking to a guy that has a fist-sized tumor in his chest. He was about to turn doctor on me and could see the look on my face, and he started laughing too. Well, you got that going for you too. But I haven't missed very many, and now I have no more blood. I don't have any more blood clots. Lots of these stories, I try and tell with humor. I try and always come by and be positive. Has it been positive from one day to the, for the whole 24 months, 2 years? Of course not. That'd be foolish. My pants would be on fire. I'd be lying so much. So, but for the most part, you wake up every day. You get on with it. I actually coughed up a lung. I took a picture of it. Yeah. Magic Red Elixir took care of that. I don't know what kind of cough medicine that is, but it came in a jug and it came red, and you took that and it took care of everything. You could sleep, you could stop coughing. It was wonderful. We didn't use that very much after a while because I thought to myself, I think that you could be on the Magic Red Elixir a lot. Don't do this anymore. In closing, I don't want to take up very much time. I want to make sure that everybody here, pays attention to the people that are around you. I haven't had to tap myself into as many programs as you had, that you're able to. I've had good family support, got a son and a daughter, my wife. I actually got to see a grandson that I shouldn't have been able to see. He should have never have known his grandfather. Now he's only 1 year old, he still doesn't know. At least he can say, yeah, I peed on my grandfather. Life is good. Those are the most important things, I think, that we can all learn from this. I can't, unlike the previous speaker, I can't tell you the name of my cancer. Don't know, don't care. It ain't there no more. What care? I asked once, and the words were, from Dr. Juergens were about this long, and they just went, I don't need to. What do I need to know? I need to show up every now and then. I need to pay attention, I need to do this, I need to do that, I need to do that. Not go to Dr. Google, and not pay attention to, as you say, Aunt Betty. Because as soon as I get stage 4, for sure you're gonna die, lung cancer, I am king of the family game of top that illness. Everybody has it, we all sit around, oh no, my God, and down. I win. Nobody plays me. I got to go back to Alberta last summer, see my family. Never thought I'd see them. So, here I stand, still alive, still kicking. I'm not the poster child for Pembroke yet, but I'll be working on it. Thank you.
I remember meeting Murray at the beginning. I remember 140-pound Murray. I also remember feeling so much better. I'm tired of being retired, so I'm going back to work, Murray. I remember meeting for the first time Grandpa Murray. I'm very excited for him to transition into survivor. Murray with stage 4 lung cancer. So thank you for that. So I'm next up on the docket. So as I mentioned, my name is Juergens. I'm a medical oncologist that works at the Juravinski. I headed the lung group for a decade. I'm briefly heading it again right now while one of my colleagues is on parental leave. But I also hold a role leading our clinical trials unit. And every single lung cancer patient who's in this room has benefited from those who came before them who participated in clinical trials. And it's through clinical trials that we continue to make progress and have more and more folks who are able to live longer and better lives in this scenario. So I'm going to spend a couple of minutes talking about clinical trials. So what are clinical trials? Clinical trials are research, involving people. All right, so clinical, patients, trials. And as I mentioned, through clinical trials, we find new ways to improve the treatments as well as the quality of life of people with diseases like cancer. Now, it's not obviously just a cancer thing, but that's what gets me up each morning and gets me coming to work. There's lots of different types of trials. So there's actually prevention trials that are out there. I remember when I was first in practice, we were looking at a particular type of vitamin compound, trying to see if that would reduce the risks of lung cancer. Dr. Finley started our talk today talking about screening trials, and that's how we learn about new tests that might be able to find cancers at an earlier stage, or potentially even identify people before cancers have developed and put strategies into place to try to prevent them from developing. There's treatment trials, and Dr. Phillips showed you a whole myriad of those. And there's also supportive care trials. Without supportive care trials, we wouldn't have the medications that prevent the nausea and vomiting that many of our patients would otherwise have experienced. Lots of different side effects that we want to make sure that we try to prevent if we can, and so supportive care trials are really important. So if I talk about prevention trials, again, prevention trials are not with patients, they're with people. I know that's like, well, I'm a people too, Dr. Juergens. But these are involving people who don't have cancer yet, but are potentially at risk for cancer. So either no cancer or at high risk for developing cancer, or have had cancer and at high risk of having a cancer come back. And so there's a couple of different types of prevention trials. There's something called action studies. So things looking at, should you exercise more? Should you eat a different diet that might be able to do things like prevent cancer? And then there's agent studies, things where you take something, whether it's a mineral, a supplement, et cetera, trying to prevent cancer. And the types of questions these types of trials answer are, is it safe for a person to take this? Like we've learned all sorts of things about simple things like aspirin and what its safety looks like. And we've actually changed our mind on aspirin a few times for different reasons over the years with respect to both cardiovascular health as well as cancer. And then secondly, just a new approach actually to prevent cancer. So then there's screening trials. And like I said, Dr. Finley has shown you some of the evidence on why screening trials have really moved the needle in lung cancer. This is really in an effort to try to test a new way to find the disease early. And hopefully then it's most easily treated. Dr. Finley argues that if we could put CT screening into place, people like me will go out of business. I'm happy to be out of business, but ideally if we can find cancers at the earliest stage, you may not need a me. So if we could get away with more surgeons and getting these cancers earlier, all better, and the most cost-efficient thing for us to do. So to have an effective screening test, you need to reduce the number of deaths from cancer in those being screened. But believe it or not, that's a harder bar to jump than you realize. So did you realize that lung cancer screening is the only screening test that actually leads to people living longer? Not just from lung cancer, but living longer in general. So there's no mammogram that does that, there's no pap smear that does that, there's no colonoscopy that does that. Those impact those individual cancers, your chance of dying of colon cancer or breast cancer, but doesn't actually increase your chance of being alive after the test. Having a CAT scan for lung cancer screening actually increases your chance of being alive, period. So that's why it's so critical for us to figure out how to do this as well. So it's not that simple though, because it seems like logic. Well, if I have something that might diagnose cancer, why don't we just do that for everybody? But we've had to answer some of the hard questions, like does finding disease earlier actually make a difference? And that's where we've come back and forth with things like this test called a PSA, a blood test for prostate cancer. Almost every man who lives to the age of 90 will have prostate cancer cells in their prostate. Doesn't mean that that's going to have any effect on their life or longevity. But so we got to figure out, do we diagnose it just because it's there, or when do we need to find a cancer? And then is the technology one better than the other, or do we need to do a combination of technologies? And then this is the piece that's been the hardship for lung cancer is when you do a CT scan of the chest, you get more information than information about the lungs. So Dr. Finley told you, we get information about the heart. We find out that someone may have calcifications that might lead to an earlier heart attack. Well, gosh, now I've got to send you to a cardiologist to find out, do you need anything to intervene on that? You might find that you've got emphysema and maybe you need inhalers or things like that to try to improve that. There's lots of different things that we can find on a CT scan, and it's getting that good radiologist who doesn't send everybody for a biopsy for every little thing that then can come with a complication or risk. What I do every day is this, treatment trials, right? And so, most cancer treatment trials are studies that involve people who already have cancer, right? These trials are testing new treatments, such as drugs or vaccines or new surgeries or radiation or combinations thereof. And many of these new treatments, we used to just treat people as a whole, right? So I would treat someone based on what a pathologist could see with their eyeballs. So they could tell me, well, this looks like a lung cancer, this looks like a colon cancer, and that was the information that we had. Now that's not what we do at all. Now I know that someone has an EGFR mutation in L861Q, or somebody has an EGFR mutation in L858R, or somebody has a PD-L1 expression of 100% that tells me that they might benefit from immunotherapy. And so I can't do my best job of personalizing the care of the people who sit in front of me without having these technologies to help inform how do I match the right treatment to the right patient at the right time. And so these are all really important things that we figured out through clinical trials. So as I mentioned, there's all sorts of different types of trials. Like some of the things I'm doing are trying to figure out what's the safe dose. Dr. Phillips talked about some of these fancy new drugs. We're working with a new, what we call antibody drug conjugate, one of her smart bombs right now. We're still trying to figure out, do I have to cap the dose for somebody? Like one of the patients we treated here is taller than Dr. Finley back there. So the dose that he got was different than the dose that one of my other patients, June, who's back here, might otherwise get. So should we really be dosing on weight? Should we cap that weight? Should we be dosing it twice in a month versus just once and then waiting to see where the dust settles? So that's some of the stuff that we do. How should we give it? So believe it or not, you've heard a little bit from Murray about this drug called pembrolizumab. You've heard about some oral therapies, targeted therapies. Murray had to come in and schlep and wait and see me every 3 weeks and then wait in the chemo suite. And he figured out how to work the system to make it such that he waited as little as possible, but there was still a lot of his life that he spent waiting. Well, there's new technology where they're looking at giving drugs like pembrolizumab through a subcutaneous injection. So maybe in the future state, you don't have to come into the cancer center to get it. Someone can come to your house and they can give you an injection right into your belly, and instead of having to put out your arm and getting an IV, maybe you can get it injected underneath the skin, and that's good enough to do treatment for a period of time. And we've got some treatments like that, where when we give the drug intravenously, it comes with a high rate of something called infusion reactions. So that's when the medicine is going in and all of a sudden your back starts to hurt, or you start to feel short of breath, or your chest hurts. And we have to stop the infusion. Nurses get very, very excited. And then eventually these things settle down. But there's a new treatment for EGFR mutated lung cancer that the risk of these infusion reactions sits at around 50%. So almost everybody is going to have some sort of reaction to these drugs, and so they've had to split it across 2 different days. Well, now we've learned that if we give the drug subcutaneously, the reactions go all to 0. So it's a safer way to deliver that treatment with fewer side effects, with the same effectiveness when it comes to its chance of getting the cancer to shrink. Does the treatment actually leave people living longer, right? Does it actually get the cancer to shrink, or does it prevent it from growing and spreading to new places? These are endpoints that we use to try to assess a treatment's benefit from a clinical trial. Those things are great, but what any of my patients care about are, what are the side effects? What's the cost to me? Like, what is it going to do to me to be able to go through all of this? So we need to have an understanding of what the side effects are going to look like. Not only do you want to know what the side effects look like, but what does that do to something called quality of life? Like, how am I going to live? And am I going to live well with this treatment? Or am I going to have so many symptoms and side effects that I can't go anywhere? There's quite a famous medical oncologist who practices out of the Princess Margaret. Her name is Frances Shepherd. Frances has absolutely made her mark on lung cancer treatment. She was responsible for the first EGFR inhibitor to be approved in Canada, and she was responsible for the approval of a drug called docetaxel that has changed practice across the world. And she minces no words, as a woman of her stature has no need to. But one of her famous lines is, we sometimes as doctors get a little cavalier about side effects, right? I get to see you for 15, 20 minutes, maybe every 3 weeks, maybe every 2 months, whatever it might be, and I get an itty bitty glimpse into what your life looks like in those few minutes. And I'll tell you, it's really easy for patients to pretty themselves up, so I think that everything is well with the world, but what I don't get to see is what's happening in that 99.9% of the time that you're not sitting in front of my face, that you may or may not be telling me about. But one of her famous quotes is when we do clinical trials, we try to quantify everything. So we list the side effects, and then we list the severity of these things called grades. And so, for example, her favorite one is talking about diarrhea. So I think everybody in this room has had diarrhea at some point in their life. And so grade 1 diarrhea means you're having bowel movements 2 or 3 times above what your normal would be. Grade 2 diarrhea is 4 to 6 bowel movements above what your baseline would be. Grade 3 diarrhea, 7 bowel movements more than where you should be, and 4 you're in hospital and poop is not staying where it's supposed to. We as medical oncologists will often get very cavalier that grade 1 and 2 are mild side effects, and she will always stop us and be like, you aren't going to the movies if you have grade 2 diarrhea, because 6 bowel movements, that movie ticket ain't getting used to the best of its ability. And that's the thing that we have to remember is each of these little things, it's one thing if you have to deal with it once in a blue moon, but if you're on a treatment that you're going to stay on for 2 or 3 years, and you're pooping 5 times a day, that may mean that you're not willing to leave your house. Like, this was a conversation I had on the phone this morning, was giving a patient strategies on how she can get out of her house because she's got a particular cancer type that causes diarrhea. It's not her treatment, it's her cancer that's causing it. And she wants to be able to go and socialize some more, and so we're trying to figure out how to make that happen. So it's really important for us to understand not just the side effects, what that impact is on the quality of life. Because some side effects don't necessarily affect people's quality of life so significantly, but others really can make a huge impact. And then, does it actually prevent the cancer from coming back once the treatment is finished? And that's a really important part of some of these adjuvant trials. So I mentioned supportive care trials are important. It's looking at improving that quality of life and helping people do with everything from coping with pain, might be nutrition, might be trying to reduce infection or nausea, vomiting, sleep, depression. Sometimes that's using medications. Sometimes that's using other things. Like we're doing a trial right now in leukemia with one of our next speakers, Dr. Zhang is critical in this, just looking at does early psychosocial oncology support help improve the quality of life of our patients with leukemia. And you can imagine these folks, they show up and they're trapped in the hospital for most of the time at a month, if not more, from the very beginning. And these are sometimes younger folks or sometimes older folks, and how do we want to help these folks improve their quality of life? So the questions we try to answer in these trials are, does this treatment actually affect patients and their loved ones? And then how do we improve the comfort and quality? So there's multiple different types of what we call phases of clinical trials. Most people are familiar with the one on the far end, these things called phase 3 clinical trials, because these are the things that lead to Health Canada potentially saying that a new treatment should be available to Canadian patients. This is often where we're comparing treatments, what's the old standard to what's a potential new standard. These trials take a very long period of time often to do and are hundreds to thousands of patients. But before that, there's other clinical trials, like phase 1 trials. These are one of my favorite things to do, where I'm looking at the brand new squeaky toys and drugs that are coming out and trying to learn what's the right schedule, what's the right dose, what side effects do we experience, how do we prevent those side effects. These trials are often smaller, although interestingly enough, the first human trial of the pembrolizumab you heard about actually had 1,000 patients on it. Multiple different diseases, because each disease responds a little bit differently, and so they kept expanding and expanding to different patient populations. Next thing you know, we're at triple digits. We probably shouldn't keep doing that, because that was not necessarily the best way to do a study, but it has been done. Phase 2 trials are looking at the middle, so it might be looking at a lung cancer and trying to figure out how likely is that tumor to shrink from a fist to a half a fist, that kind of stuff. We also sometimes do these things called phase 4 trials. This is after a treatment is approved. Because again, we might have treated a few hundred patients to approve a new therapy, but you know what? Some of these side effects are rare. So what if you get a side effect that only happens in 1 in 1,000? I would have potentially never seen it during the clinical trial, but that still might be really important for us to know. And so sometimes we'll keep collecting information even after, and sometimes this is a mechanism for patients to access these treatments while the provincial bodies are determining if they're going to fund a treatment. So sometimes we do phase 4 trials as well. So, what is the terminology that we use in trials? One of the things we talk about is something called randomization. We'll often talk about flipping a coin. There's no money and exchange involved here. It's actually now all done by computer, where a patient is assigned to 1 or 2 groups, and that's often happening in those later phases of trials. Sometimes in phase 2, almost guaranteed it's going to happen in phase 3, where half the patients will get assigned to group A, half the patients will get assigned to group B. Part of the method to the madness here is we're trying to make 2 groups comparable, and it turns out that process of randomization does one of the best jobs that we can at trying to equally divide things that we can't necessarily appreciate, right? So I can pick a few things. So I might pick that I want to balance the number of men and women in a trial, or I might pick that I want to balance the number of people from Asia versus North America, et cetera. But there's some things that we don't understand yet, we don't see. And so randomization tries to help balance the chances that an equal number of those unknown factors will end up in each group, and that's really important for us to understand the effect of the treatment. You may have heard of these things called placebos. Not every trial comes with a placebo. I think that's one of the biggest worries of folks is if somebody participates in a clinical trial, they're going to get something called a sugar pill or sugar water. A placebo is a substance or other treatment that looks like treatment, but it's not. Why do we do that? So part of the tricky part is doctors they always try to be helpful, right? And so sometimes we think we know better than what the evidence has told us. And so sometimes placebo controls can actually help get rid of that effect of the doctor potentially making a decision before the data is actually available to us to help do that. Believe it or not, we get people who have side effects from placebos. So that's an important thing for us to know when we're trying to figure out what side effects are actually just the disease. And some people get better with just placebos. So that just tells us a little bit about the natural history of the disease and what's gonna happen. This is a big one, right? Am I a guinea pig, right? I gave a presentation to our patient and family advisory council at the cancer center. And one of our esteemed advisors was like, but clinical trials isn't relevant to the vast majority of people who walk through these doors. He's like, you only do that if you're desperate and you're at the end of your options. And I'm like, absolutely not. Clinical trials are for everyone potentially. And I think people are worried about being a guinea pig. So actually, if you ever come to my office, not my clinic office, you will see my guinea pig. I actually had a patient give me a guinea pig. He is stuffed. He's not going to be like a Beanie Boo or whatever it is, with a lovely little inscription on it, thanking me for never making him feel like a guinea pig during his journey, right? And so, no, that is not how we see things. No, we're not somebody who we're experimenting on. And I didn't come from here. I came from the US. I didn't disclose that at the beginning. I probably should have. So now you know to take everything I say with a grain of salt. I'm American. But I practiced at this place called Johns Hopkins. And Johns Hopkins has a wonderful reputation now, but it didn't have such a great reputation back in the day amongst its own local community. And it's because they were research first, but they were research first potentially to a detriment. And there are many people from the Baltimore community who are afraid to come near Hopkins because they were worried that they were going to be taken off the street and experimented on. And it's actually a book that I encourage everyone to read that's called The Secret Life of Henrietta Lacks. She was a woman with cervical cancer who received treatment, and they took a piece of her cervical cancer tissue and they actually made something called an immortal cell line. Henrietta Lacks has probably improved the lives of more cancer patients than just about anybody on this planet because we have learned so much from all of the experiments that have been done because her cancer cells don't die. So we use them in innumerable experiments. They've literally been kept alive for decades. She had no idea that her cancer cells were being taken and then going to be used in science, right? Not that that was a bad thing, but nobody told her, no one got her permission, no one got her consent. And so that legacy is not the right word, right? Has held with us, and that people have been fearful of the research in Baltimore since then because of concerns around wanting to make sure that you're not treating people like a guinea pig. So, we have all sorts of things because of things like that. Back in the day, like this is the sadness. Medicine was a very different space back many years ago, just like thoracic surgery was different for Dr. Finley's grandfather. There was no bar for ethics. So we had surgeons who said, gosh, when my surgical patients with cancer get an infection after the surgery, if they survive it, they're the ones who live longest from their cancer. So we had a surgeon who created his own sort of infectious serum called holy serum and started giving it to his post-surgical patients, started giving them a controlled infection with the hopes of leading to their cancers living longer. There was no consent. It was his daughter who ended up writing up the data afterwards. He's the godfather of immunotherapy, right? He's the reason why we now understand how to use our own immune system to fight cancer. But this was long before we had these things called research ethics boards that make sure that everything that I'm doing is patient-centered. We have scientific experts. We have now patient experts who sit on these different spaces to make sure that we are taking care of the patients with whom we are entrusted. So if you want to know a little bit more about trials here in Canada, this is from the Canadian Cancer Society. This just looks at what we're up to. Now this is 2020, right, so before the world decided to try to end on us. But you can see that we've got centers across this country that participate in cancer trials, and there's hundreds of centers and thousands upon thousands of patients. This is really looking at the Canadian Cancer Trials Group, but there's trials that are happening all over this wonderful country. If you look here at the JCC, we do trials that serve the patients of this general region, Hamilton, Halton, Niagara, Brent. We also are a referral center, so we take patients from Western Ontario, London, Grand River, Cambridge, Windsor, Oakville. And And we do all those trials that I was just telling you about, chemotherapy, targeted therapy, immunotherapy, radiation, the combination thereof. We're now playing up and down the hill where Dr. Finley sends me people and we're gonna give them treatment. I'm gonna send them back and let them do an operation. He's gonna send them back and we're gonna give them some more therapy. So we're learning to play together to try to better the lives of our patients. We do supportive trials, we do prevention trials, and we do all the different phases. So we have all sorts of different people who help make these trials go. So we've got the Canadian Clinical Trials Group, or CCTG. We work with some of the US cooperative groups to do international studies. We have our own local Ontario Clinical Oncology group that does both local trials as well as national and international trials. Our own foundation sponsors some of our investigator-initiated trials. Actually, I'll introduce Dr. Koski, who's in the back here, Andrea. She's going to be our newest faculty member and has been working tirelessly to help get our ability to do those liquid biopsies that Dr. Phillips had mentioned, where we draw blood and we can characterize what's going on in the bloodstream. So she's been working to get that. And what our hope is we're going to embed that in Dr. Finley's lung diagnostic assessment program. So as he suspects someone has stage 4 lung cancer, we'll draw their blood and see if we can start the characterization process then, trying to shorten the window of time that it takes for a patient to go from a suspicion of lung cancer to me being able to make a treatment decision. So right now it's incredibly too long. And then we have industry partners who do trials with us as well. So we've got a mix of all these different groups. So if you haven't had a chance, we've got a website, come and check it out. This is Greta. Greta is an absolutely incredible patient advocate. She's a 10-year survivor of a specific type of blood cancer. She's actually from Baradzie. And she didn't like the idea that they didn't have a research trial for her, and she wanted to see what was better. And so she trucked all the way to Hamilton, back and forth for years, and still comes. She's actually here this week. To participate in a clinical trial, and she's in remission a decade later because she decided that she was going to ask those tough questions about the doctor's recommendations. So we've got that. We've actually got now a website where people can go to try to find what trials are out there from a cancer perspective, run through a group called the Canadian Cancer Clinical Trials Network, or CCTN. So you can search for lung, you can search for EGFR, or any of those different types and find out if there's any trials and where they are here in Canada. And then there's actually a human. What? A human? So that same group called the CCTN funded a pilot, and they're going to extend it now, and it's actually run out of Windsor, where you can call somebody and talk to a human who will help you with this, right? I know we've moved all to AI and search this website and all this kind of stuff, but we've also decided that sometimes having that human touch is important too. So before I proceed, I did say that I was going to make mention. We've actually got a clinical trial participant in our midst here. Larry, I'm going to ask you to wave your hand for me if you don't mind. And this is, yes, you're going to wave your hand. Everybody sees Larry. So we're going to all give a round of applause for Larry. So you are amidst the very first human on this entire planet who signed up for a clinical trial after having a surgery for his lung cancer, and we gave him chemotherapy after that in an effort to try to keep his cancer from coming back. He was the first person on this planet to ever receive immunotherapy that has affected so many people in this room in the post-surgical setting, and it's now become something that's standard of care. Didn't end up keeping Larry's cancer from coming back, and he's now the benefit of one of these tablet-type treatments that are out there. But it's on the shoulders of the Larrys of the world that we continue to see progress and things moving forward. So I wanted to thank you for everything that you have done and being brave enough to say yes to a clinical trial. So that is the last of my slides. I'll take any I'm just going to introduce the two of you. So I'll start with Ruth, who is up on the top. So Ruth is one of the amazing social workers who works at the Cancer Center. She graduated from Wilfrid Laurier with a master's in social work. And she has been working at the Cancer Center for over a decade and provides support on innumerable levels to the patients at the JCC. She is partnered with Dr. Karen Zhang. Again, I cannot underscore how incredibly fortunate we are to have Dr. Zhang as part of our team. She is a clinical health and rehabilitation psychologist. She's head of service for the adult psychosocial oncology program at the Juravinski. She works in the Department of Psychiatry and Behavioral Neurosciences at McMaster. She's actually the psychosocial oncology regional lead for Ontario Health. And she has made an incredible impact on the mental health of our patients. And Karen and Ruth are going to talk to us a little bit about how do we deal with our mental health and interacting with the world around us. So thank you guys for coming and joining us tonight.
Thank you so much, Dr. Juergens, for having us. This is a little bit bizarre, and I don't know about Ruth, but I can't see myself, so if anything is kind of looking kind of strange, I apologize. But in case, this is actually a really nice segue from some of the discussions we heard Murray say in terms of relationships, and also what Dr. Juergens was saying in terms of just kind of clinical trials. And there's a huge part about how does the cancer experience impact quality of life, and certainly relationships is part of that. So I think I'm going to pass things over to Ruth to start us off on this conversation. So Ruth, just let me know when you'd like me to proceed with the slides.
Okay. So hello, everybody. As I get started, I'd just like to put two things into your mind and say that we know cancer affects not only the person who is diagnosed, but the people with whom they have relationships with. And the other thing I think that's important to remember is that relationships change over time, whether they're someone affected with cancer or just two people in a relationship or more people in a relationship. So I think those are important grounding principles maybe to keep in mind. Okay, next slide. So when I can't see the slides, so I'm just trusting that they're there. So emotions that are associated with cancer. So I know that some of the people in there are cancer survivors and been diagnosed with cancer. So you might remember back to when you were told you had cancer, and you might have had a number of different kinds of emotions. You might have felt fear, you might have felt sadness. There might have been some anger, or you felt irritable that, this is an unwelcome intrusion into your life. Perhaps you felt some guilt. Perhaps you felt shame. Perhaps you felt relief, because sometimes people go through a lot of testing or waiting for tests to come back, and you think it might be, but you don't know for sure. And sometimes when you actually know what it is a bit of a relief. So it's normal, though, to want to try and get rid of negative emotions because they feel unpleasant. And nobody likes to feel irritable or angry or sad all the time. So we try and find ways to change those feelings. Next. So we can deal with our emotions in different ways. Some people do the following to deal with negative emotions. They might suppress or avoid unwanted emotions. They might control unwanted emotions, so you hold everything in, or you act on intense emotions. So, that's where you yell at people and, you're very short-tempered. Or the opposite, I guess, is that you might withdraw from others and, become a bit reclusive or locked in your bedroom. So, in thinking about these different kinds of emotions, what can be unhelpful about only using these types of strategies to cope? Anybody? Okay. Well, these aren't healthy ways to deal with emotions, and they have other repercussions on our health and our emotional well-being if we don't act in a positive way with our emotions. So the next slide is kind of this circle of the way feelings work. We might be diagnosed and trying to do more things around the house, but then we feel frustrated because we don't have the energy or the time to do things the way that we would like to do them or as often as we would like to do them. And as our frustration mounts, then we try not to feel angry, but sometimes we do. And maybe we snap at other people or are very short-tempered. And then when we act that way, then we feel guilty. So it's kind of a negative circle of emotions. And we need to try and break that circle of emotions. So how do we do that? Well, we manage these emotions that are driven by anxiety. And some of the healthier ways to manage our emotions is to, one, be aware of the emotions that we're feeling and being able to, identify, are we happy? Are we sad? Are we angry? And then to validate the emotions. If you're feeling that way, you're feeling that way. And, if you identify it and validate that this happened, so you have responded this way, then you can attempt to start to process the emotions and to understand it. And by processing it and understand it, you'll come out with perhaps a better way to deal with things. So what do we mean by processing emotions? Sometimes it might feel like a tidal wave. So processing emotions means allowing yourself to feel those emotions without pushing them away or judging yourself for feeling that way. So that, again, is sort of giving yourself permission to feel it and to identify it. And remember that emotions do not last forever. Even if you're feeling angry, your anger will dissipate over a period of time. And that's maybe when you can start to really process what's going on. Well, I think we're turning it over to Karen now.
Thank you so much, Ruth. I think this was a really nice overview of course, the diagnosis, treatment, and even in the survivorship or aftermath of cancer, it really does impact, all of us, including not just our physical health, but our emotional health as well. And I think this last point, just to highlight, is that a healthy mind is supposed to experience all emotions. A lot of times there's a lot of emphasis on it's more healthy to experience positive emotions, and that's not true. Those feelings of sadness, anger, all those ones that Ruth has listed, they're all part of a healthy mind. So we do have to make room for those emotions in order for us to feel more well-rounded and also for us to feel well. So again, just to summarize, emotions are meant to change and to adapt to the environment. So if you are having those bad days or finding yourself feeling more emotional, is perhaps to give yourself a little more room to experience those emotions, knowing that they won't last forever. I just had a very intense lightning. I hope I'm still on the screen here.
You're good.
All right, so kind of a nice segue to that is, of course, our emotions have profound impact on us as individuals, but it can also have profound impact on relationships and the roles that we play in not just our lives, but the lives of our family, our friends, our partners, neighbors, co-workers, etc. So this may be a little bit hard to have audience participation, but maybe just a bit of a private reflection. Thinking about how has your cancer journey impacted your relationships? And perhaps you may have noticed some positive changes. It can bring people together, or perhaps you may have noticed some challenges as well in relationships. Here are some common changes that many of our patients have shared with us. Is that oftentimes when there is a diagnosis of cancer, that person may feel the need or want to put on a brave face for others. So not wanting to perhaps burden or put more pressure on family members, and perhaps feeling the need to protect family members or friends from how they're really feeling. And we also notice a shift in the dynamics in relationships. So for many couples, they may notice that changing from a spousal relationship to a patient caregiver role can be challenging. Okay? Whereas before it's more of a partnership, but when we talk about patient caregiver, there are new challenges to that. Okay? Intimacy being one. Sharing workload, feeling the ability to contribute equally or doing what you normally do in the relationship, all that has profound influence or changes when we are diagnosed with cancer. And sometimes people really don't like these changes. So I've had many spouses or family members tell me that they don't like that identity of a caregiver. Right? But it's not one that they chose, and perhaps it was enforced in some ways. And I touched on this about fear burdening others, and that can show up in different ways because of the different treatments and because of the impact of cancer. It does have severe influence in terms of level of energy and how much one can physically do. And for many people, there's an element of guilt that they can no longer do all the different tasks or activities that they used to. And the other one, I wonder if this one resonates with anyone listening today, is perhaps feeling more irritable or having less patience for mundane things. So very commonly I hear people say, I feel badly, but I get very annoyed when other people complain about their problems. It's not that I don't care, it's just that I just have other things on my mind that it's sometimes irritating, for example, when someone is complaining about not finding a parking spot when I'm going through something that is much more profound or perhaps heavy. Another type of relationship changes, there could be some changes in the closeness of relationships. So oftentimes we do hear from people saying that sometimes they feel disappointed. People that they thought would show up or be there during their cancer journey perhaps has not stepped up or understood in the way that they had hoped. And some of these changes could be positive as well, is that there are some people that they never expected who really stepped up to the plate, or they really found a new closeness or bond with someone that they previously did not feel very close to. So there are some changes in terms of closeness of relationships as well. And for some individuals, sometimes the diagnosis of cancer can lead to a fear of engaging in relationships. So dating can be very challenging. There can be a lot of hesitations and sometimes a lack of confidence in being able to establish new relationships. And all of these different areas are quite common, and it does come up when one is diagnosed with cancer. The other thing to also normalize that we hear often is we have some of our patients tell us that they previously were very social beings, and they love to socialize with others and be in crowds. Perhaps after the diagnosis of lung cancer, they don't feel that comfort anymore. And just to kind of normalize that this is okay, and this is something that is normal after we've been through diagnosis and treatment. It's normal to feel anxious. It's normal to be unsure of what to say to others. It's also normal to want to avoid these big gatherings and perhaps prefer something more intimate. And that doesn't mean there's something wrong or you're not normal anymore, but these are some changes that happen in terms of what we feel comfortable with. So those are all the different areas that we hear often from our patients. And I'm sure that there are others that we did not list here. So when we talk about relationship changes after the diagnosis of cancer, what are some ways that we can rebuild healthy relationships or find positive changes after a diagnosis? I'm going to go over 3 different areas today in terms of building those healthy relationships. The first one, probably the most important, setting boundaries, asking for help, and the last one, recognizing your needs. So what do I mean by boundary setting? A lot of times after a diagnosis, there are many well-intentioned people who want to help. And sometimes it can be very overwhelming because perhaps, most of the help is very helpful, but sometimes it can be a bit too much. And learning to say no is a healthy skill to have when we talk about positive relationships. And here you could see that on this picture, we talk about saying no in different ways. On one end, there's saying no in a very aggressive way, and perhaps that's not always helpful in relationships. And there's saying no in a more passive way that is perhaps we are being nice and agreeable, but people may not necessarily hear us or respect our no's. And there's the balance in between the two is how do we practice assertiveness when we say no? So just use an example. A lot of times it can be very hard to ask for help, and it can be disappointing or frustrating when we do work up that courage to ask for help, and perhaps we're not getting help the way that we would like. So an example here is, for example, after treatments, one may feel very tired or just have less energy to begin with, and we can no longer pick up after our family members, so we tell them that they need to pick up after themselves. But what happens if perhaps family members forget or they don't hear you? So over here on the right side of the screen is the desk script. This is just a simple way or a template to help us describe what we want, and more importantly, what are the consequences or what would happen if what we ask for doesn't come true. Not in a demanding way, but just to kind of be clear in terms of our expectations. So in this case, if the example is telling our family members they need to pick up after themselves, first we want to describe the problem. I come home, I'm not able to do all the things I used to, and then when I see, this messy home, it makes me feel more frustrated. And specifying the change you'd like to see. So I would like everyone to please pick up after your own mess. And the consequences of if I don't see that, I will try to clean up, and that would only exhaust myself further and lead me to feel more frustrated. So I think it would be better for everybody if everyone just picked up after themselves. So in this way, it's really being clear about what you want and also the consequences of what would happen if that did not come true. The second point to building healthy relationships is asking for help. So why is this so hard? And also, why is this so important? Asking for help is very hard because for many people, I imagine here today, they will say that I'm usually the caretaker in the family. I'm usually the one that people go to, and I'm usually the one who's helping others. So it sometimes feels very unnatural, and I don't like to bother others for help. Why it's important, however, is that oftentimes energy is limited after a diagnosis of cancer. And if we try to spend all that energy, try to do things around the house or the chore list, we don't have much energy left to for example, spend time with ourselves or with others. So asking for help is really one way for you to conserve energy so you can spend it on activities that mean the most to you. But also why it's important to ask for help is sometimes it's really helpful for family members to know what they can do to help you. In that way, for many caregivers and for family members, they can feel helpless, not knowing how they can contribute or how they can help you through a stressful time. And by asking for help, it's a way that allows them to feel like they're doing something in a situation that is difficult to navigate. And getting close to the end here. So another very important part, of course, is recognizing and communicating your needs and healthy relationships. So sometimes when we talk, we have family members who maybe want to cheer us on and tell us to stay positive. And sometimes that's really helpful. But sometimes we may not want to hear that. Maybe we just want space to vent. Maybe we just want to feel validated. Maybe we are asking for someone to help us find a solution. And maybe it's to be clear with our family members and friends in terms of what we're looking for when we propose or describe a problem. The last part is think about who's a good support. So I mentioned this before, is that after a diagnosis, oftentimes who we consider to be a close support can change. Right? So for example, the childhood friend that we had, they might be in our inner circle before the diagnosis. But after the diagnosis, while there's still someone that we cherish and we feel close to, they just may not understand everything that we're going through. So maybe they kind of move out a little bit more to the outer circle. And maybe that person that we met while we're in the waiting room at the Juravinski, we've connected with them and they really supported us through the cancer journey. And that's okay. And sometimes it's okay to just lean towards the supports that we feel is most helpful at the time. So just a little bit more about social connectedness. So sometimes it's not just about the circles that we come with before the cancer diagnosis. Sometimes it is about expanding our circles to other communities that we know provide that support. These are just a few that we've listed here. Ruth is quite a guru in terms of knowing many others, but just to highlight, so the beautiful space that you're in, or some of you are in right now, of course, Wellwood has wonderful programs. Wellspring, Pink Pearl is a program for women under 40 and under who are diagnosed with cancer. Young Adult Cancer Canada also has many resources, along with Lung Cancer Canada and also Canadian Cancer Society. So these are all great ways to feel more connected. And that brings us to the end of the presentation for today. Any sort of thoughts or questions for me or myself?
Dr. Zhang or for Ruth?
Sorry.
I think that you've given everybody lots of food to think about, whether you're a cancer patient caregiver or somebody cancer adjacent. I think a lot of the things that you've said have resounded true. So I just want to thank both Ruth and Dr. Zhang for everything they've done to help support the quality of life of all of our patients who have interacted with them at the Juravinski. So thanks, guys. Okay, well, we're coming to the close of our evening, and we would be remiss if we didn't finish off with one more patient story. So it's my pleasure to introduce Claude Davenport. Claude comes to us via Montreal, so we've got Alberta to the left and Montreal to the right. He actually retired after working for 31 years for General Motors Canada, and he's the human resources and labor relations expert. And he and his wife Heather live in the Niagara region, and I'm always looking forward to hearing about how quickly he's going to get out golfing each year. It's one of my favorite things is to hear about the things that my patients get to do. So he's going to come and talk a little bit about his journey. He's on the other end of the spectrum for everybody, and he and I got to have a 5-year celebration recently.
Thank you, Doctor. Good evening. So I'll start with when I was told that stage 3 lung cancer in 2018. But I need to put this in context, I think, for better understanding, and with that, some of the emotions I went through along the line, and then I want to share with you my takeaways from this journey. So it happened that in 2014, I was diagnosed with prostate cancer. To my surprise. I had no symptoms, everything was hunky-dory, like we say. Had my physical, but our family physician said, I think you need to go to the clinic at St. Catherine's Hospital, and you need a biopsy. I was a little bit shocked, but I was not really down about it. I was concerned, don't get me wrong. Anyway, we go through the biopsy, first one, and everything is okay. They're gonna put me in a surveillance program for a year, so I think this is somewhat likely. The following year, second biopsy is no good. So now, for the first time, I'm really at the crossroads. Some people are suggesting I should have radiation, others say surgery. I elected surgery for the better. I go through surgery. I go to follow-up meeting with the surgeon, and he says, who's talking to you about the spots on the lung? I said, I don't know what you're talking about. Nobody ever told me about that. And then he went on to say, who's telling you about CLL? I said, I don't even know what that is. Right? And I'm not good with medical terms. So he explained that it's a blood disorder in the family of leukemia. But he put it in a way that, I'm going to send you to an oncologist and see what can be done there. That being said, the long issue is reviewed by Dr. Finley at the St. Catherine's Hospital. Conclusion is I need surgery. So December 16, following my prostate, I diagnosed prostate cancer in 14, surgery in 16 September. Come December, I had my first long surgery with Dr. Finley. Then I'm under surveillance by Dr. Finley. We moved to August 18, 2018. Here's my second surgery. From there, and I must say that all through those years, I was feeling good. I had no symptoms. I was, just having a normal life. As Dr. Juergens said, I was playing golf every day. My wife and I would travel. I had no symptoms. So this comes as a big shock, all this together. And obviously, between Dr. Finley and Dr. Juergens, there were some concerns about why do I have so many cancer so many times, for lack of a better term. So I went for a biopsy, and the results were not stellar. I was told that I had stage 3 lung cancer, and that in my interpretation of it, the lymphoma was too close to the heart to have surgery. And Dr. Finley said, you're gonna go back and see Dr. Juergens. And of course, Dr. Juergens had the results as well. So now, I get, if you want, on the emotional roller coaster. I'm thinking, so what now? What am I gonna do? And I went through the first 3 surgeries, and I was fairly even keeled, but the stage 3 cancer kind of took me aback. It brought frustration with me. I wasn't frustrated at the people. I was frustrated that after all I went the last 3-4 years, how come I'm going through this one now? Right? You go through this, as I said, emotional roller coaster. And I must say, my wife came with me for every medical appointment, whether it was with Dr. Finley or with Dr. Juergens. And that was very important to me because she was great support. And so when we left Dr. Finley's office and he said, I can't do surgery, needless to say that I was shocked, I was down, and we're walking towards the car. And she said, we're gonna go through this. That was important to me in terms of support. And so we visited with Dr. Juergens in October, November. The stage 3 cancer diagnosis is there. And then, I can't see clearly, I'm thinking, I ain't gonna make it. That's what I'm thinking. And that's a pessimism. So in early December, we go visit Dr. Juergens, and she says, I've got a treatment plan. The treatment plan consisted of 6 weeks of radiation, 5 days a week, 12 hours of chemo, concurrent with radiation, and then immunotherapy after that for about 10 months, if I recall correctly. And so the radiation, I was okay. The chemo, concurrent with that, not so. Now, I don't have any medical expertise. I don't know a thing. I confess to that. I'm not Dr. Google. I don't do that. Matter of fact, when I go for my scans and I know I can access the reports, I usually don't read them. And most of the time I don't. Why is that? I don't understand the medical terms, right? So for a medical person, that's easy to understand. For a neophyte like me is, I don't know what this is all about. Is it good, bad? And then your head starts to turn to the negative for nothing. So that's why I kind of take the opportunity when I visit with Dr. Juergens to review the report. Because you can verbalize that in terms that I understand. And to me, that is very important. And for my wife as well. Right? So she's been with me, my wife, all the way through this. We go through the surgery, we go through radiation. And as I said earlier, about the chemo concurrent with radiation, I don't know, I didn't see that right. Dr. Juergens kind of got me on the right track and said, if I do it concurrently, that will improve your chance of success. And that kind of turned my pessimism, if you want, into optimism. And there comes a question. And I don't know if it's because of my training or my years working. I want to know the chance of success. I mean, we've got the plan, but is that going to work? So Dr. Juergens says, well, about 30% chance, give or take a couple of points, depending on the formulation of the chemo. So now I'm at the crossroads. I don't have any options. If you get to think about it, you don't have any options. If I don't, go and and do the treatment plan, I may not be here today. As simple as that. So I invested my total confidence in this plan, and it is decided I'm going to start to do that in January of 19. Great. And so, radiation, how does it work? I don't know. I went down to
That's okay, we don't hear
the radiation clinic, and there's some staff there educating me. I met with Dr. Swana, if I remember correctly. And so now I feel more confident. For all this, I feel more confident. My pessimism turns into optimism. And I feel that with all the medical support I get, that it works as a team. My wife is supporting me. I got the treatment plan. What is my role as a team member? Very simple. If I put time and effort into this, it may succeed. It's not a guarantee, but it may succeed. Put the chances on my side. Right? So that's how I went about it starting in December of 19. And I was determined to go to every treatment day, rain, shine, snow, I'll go. And we had weekly meetings and reviews about that, and they were all positive. And on that, very became important to me, because now you're building on the positive side. Every time you get a good report, it's a building block to hope. That's how I saw it. And I went through 5 years now, and probably had, I'll pick a number, 20 scans or about. And every time they were good, or the results were showing improvement. So those were the building blocks to me that gave me hope that this is going to be okay. Another thing that I did during that period is try to remain active, to try to keep my schedule to the extent possible. Playing golf. Do that. Absolutely. I mean, I talk a lot about that because I'm an avid golfer. I'm going to play golf. And then when we went through immunotherapy, it was every 2 weeks for a couple of hours, And that day, I was going to immunotherapy, and I go back often, on Wednesday, so I go back on Thursday and Friday. So my point to this, it was important for me to keep my schedule. And my wife was very supportive of the schedule. Okay, now you gotta go play golf and go do your thing. So maybe because of the burden in the house. She's not here tonight to validate. Anyway, so my point to all this is, it's a long road. I went through this. I went from being pessimistic to optimistic, and that I believe helped me in terms of saying, hey, I can succeed with this. And that was a driving force to keep going at it for me. So this is what happened in my history about dealing with cancer. So I was thinking the other day, what are my takeaways from this whole experience? Because if you reflect a little bit, you get to think, okay, I've done through all this, but what are my takeaways from that? First, I needed to ask questions and clarifications. As I said, I'm not a medical person, so if I read a report or if the terms are too medical, I'm not getting that information. I can't process the information, so I need to ask questions, clarifications. That's very helpful. You may not like the diagnosis, you may not like it, but you can't escape it. You can't deny it. So turn your mind to, hey, how can I cope with this with the support from the professionals? So that was another thing, another takeaway. Understand what it means to go through radiation and chemo. I didn't understand that, right? I didn't have a good, they told me, well, you need to get tattooed. Really? For what? Well, we need to mark you. That was the thing. We need to mark you for radiation. Oh, okay. They do that. And that's fine. I didn't know that. So I met one of the supervisors in radiation, Lucas. I remember his name, young man, fine young man. And he took the time to explain to me what he was doing. I thought, and the doctor's going to laugh here, I thought radiation was like half an hour, 45-minute treatment. So first treatment, it lasted like 2 minutes. And Lucas said, we're done. I'm thinking, wow, that went bad, I guess. But that's what I learned through the process, okay? And every week when we had the debriefing, I was asked, hey, how do you feel? Are you sick? Nausea? What? No, the only thing I had was heartburns. And I was given a script and that was it. So, and there was progress. It would say, hey, it's better and better and better. So that's how I went through it. When it got to chemo, and sometimes I don't, well, not sometimes, most of the time, I don't hear very well. That's probably the next thing I should get done. Dr. Juergens said, if we formulate the chemo with certain chemicals, I'll say, it won't probably affect your hearing too much. And I thought, wow, that's encouraging. And what do I know about chemo? I thought chemo was just one formula and that's it. Obviously it's not. So my point to this, ask questions as you go through so you have a better understanding and it puts you in your comfort zone. That's what it does. Right? So listeners, takeaway. I talk about being pessimism into optimism. It's a booster for hope, no doubt. And the fact that I changed my focus to optimism, I saw that as well as very positive. Probably a very good link to that was the treatment plan and the feeling that, hey, this is a team effort. Everybody's got a role, and if you all pull together in the same direction, and my job was to spend the time, the effort, understand what's going on, chances that it might succeed. So that's my story. It may apply or not apply to you, I don't know, but that is my story. So. I want to thank Dr. Finley and Dr. Juergens for all their care. Without them, I wouldn't be here today.
Now, and this is one of the very first first Hamilton area patients to receive immunotherapy after chemotherapy radiation. So again, benefits from all the things that have been done. Well, I just want to thank everybody for coming out tonight. Please, for those of you who know me, we would love feedback. I would love to see this happen more often. I think it's good in bringing our groups together, whether it's for didactic stuff or opportunities to sit and chat. And that's one thing after the pandemic is we want to get people back out and get people being able to gather together. I want to thank the team from Lung Cancer Canada for keeping me poking along to get all this stuff done. So thank you to Michelle for her undying spirit moving this forward, and thank you to Winky, who's my partner in crime, at keeping patient focused when it comes to making sure that we get all these treatments brought forward. Like I said, I wouldn't be able to do all the things that I get to do if it wasn't for the two of you. So thanks to Lung Cancer Canada for sending me this.